Naomba tukae. Kwa mara nyingine tena naomba ni wasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. Asanteni wote kwa kufika hapa, na kama nilivyotangulia kusema, tunaomba radhi kwa programu yetu kuchelewa. Kama ambavyo ratiba inaonyesha, tulipaswa kuanza tangu saa 2:30, lakini tumechelewa kwa sababu kadha wa kadha. Naomba tusameane kwa hilo, na kwa kuwa muda umepotea, tutapunguza maneno. Tutakwenda haraka haraka kufuata ratiba ili tuweze kufidia muda ambao umepita. Kwa heshima na taadhima, mimi ninaitwa Selemani Mbuita. Nimechaguliwa kuwa msema chochote au moderator, lakini nitakuwa mwangalifu nisiseme chochote cha kuudhi. Nitasema chochote cha kufurahisha na kufanya kazi yetu iende vizuri. Kwa mujibu wa ratiba yetu, nitakuwa na matangazo kuhusu logistics na nini baadaye, lakini tuende moja kwa moja kwenye ratiba. Kwa mujibu wa ratiba yetu, tunapaswa kwanza kutambuana. Ningependa kuchukua nafasi hii mimi kumtambulisha mgeni rasmi kwa wajumbe walioko hapa ni akina nani, alafu baadaye tutamkaribisha mwakilishi wa katibu mkuu kutoka ofisi ya Rais TAMISEMI. Yeye atafanya utambulisho wa meza kuu. Ndugu mgeni rasmi, tunakukaribisha sana katika shughuli yetu ya hili. Itakuwa ni workshop ya siku 2, leo na kesho, na kama ambavyo umepata taarifa kwa muktasari, madhumuni makubwa ya kukutana hapa, kama wanavyotumia neno la Kiingereza, ku celebrate closure of HPSS project, project ambayo imekuwepo ikitekelezwa hasa katika mkoa wa Dodoma, lakini effect yake imekwenda kitaifa katika nchi nzima kupitia mikakati yake ya kuimarisha mifumo na usimamizi wa huduma za afya Tanzania. Ni kazi kubwa na tusingependa shughuli hii ihitimishwe kimya kimya. Kwa hiyo ndio maana tuko hapa. Kwa hiyo walioko mbele yako ni wadau mbalimbali ambao kwa namna moja ama nyingine wameshiriki tangu kuanzishwa kwa mradi huu miaka 12, 13 iliyopita mpaka kufikia leo. Hapa mbele yako kuna taasisi mbalimbali za serikali, government agencies, lakini vile vile tunao wadau wetu wa maendeleo, development partners. Kuna makundi makubwa tu ya implementing partners ambao kwa namna moja ama nyingine walishiriki katika utekelezaji huu. Kuna wawakilishi wa ngazi mbalimbali kutoka katika mikoa mbalimbali Tanzania. Tuna wawakilishi kutoka katika ngazi ya halmashauri ambao kwa namna moja ama nyingine ndio walikuwa wadau wakuu na watekelezaji wa shughuli nyingi za mradi huu na waalikwa wengine. Kwa hiyo kwa muktasari, hii ndio spectrum ya watu ambao wako mbele yako, na bila kupoteza muda naomba nimkaribishe mwakilishi wa katibu mkuu kutoka ofisi ya Rais TAMISEMI ili naye atutambulishie meza kuu, maana wanasema utamu wa mazungumzo ni kutambuana. Meza kuu ikitufahamu sisi ni akina nani na sisi tukawafahamu hao akina nani, then tutaanza kuongea vizuri. Karibu sana ma.
Jamhuri ya Muungano wa Tanzania. Ndugu mgeni rasmi, Naibu Waziri Dr. Godwin Mollel toka Wizara ya Afya. Kazi yangu kubwa ni kutambulisha washiriki walioko meza kuu. Napenda kumtambulisha mgeni wetu ambaye ni balozi wa Swiss, Didio Charsot. You are welcome to our meeting. Lakini pia napenda nimtambulishe director of the project, Manfred Stummer. karibu sana. Pia mgeni rasmi, napenda nimtambulishe kaimu rasi wa Dodoma, Dr. Magoma, karibu sana. Napenda pia niweze kumtambulisha mwakilishi kutoka Wizara ya Afya, Dr. Saitot Laiza, karibu sana. Ndugu mgeni rasmi, mimi nimemaliza kazi yangu ya utambulisho ya meza kuu, na mimi naongea hapa ni Subisia Kabuje, ni mkurugenzi msaidizi huduma za ustawi wa jamii, lakini kwa leo nimekuja kumwakilisha katibu mkuu ambaye tutakuwa naye leo mchana. Asanteni sana.
Asante kwa kazi nzuri. Kwa hiyo basi tunapenda ieleweke kwamba tulioko hapa tunaongozwa na mgeni rasmi ambaye ni naibu waziri wa afya, na pia tunayo heshima kubwa ya kuwa na balozi wa Switzerland nchini Tanzania na kadhalika. Tunatarajia vile vile ujio wa baadhi ya viongozi ambao tulitarajia watafika, lakini waliconfirm watakuja, lakini hawajaja. Inawezekana watakuja baadaye. Tunatarajia ujio wa Mheshimiwa John Ndugai, spika mstaafu. Tulidhani ni muhimu sana akajumuika na sisi katika siku hizi mbili kutokana na historia ya mradi na mchango wake mkubwa kwenye project hii na kadhalika. Na nikumbusha mwenzangu hapa kwamba lugha kuu ya mawasiliano itakuwa ni Kiswahili, lakini tuwe huru katika kutumia lugha zote mbili. If you feel like you can speak English better because you are a bit incapacitated to use Swahili, please feel free. The kind of audience, tuna hakika kwamba almost 98% ya watu walioko hapa they can communicate in both languages. So please be free to use any language. So I was reminded to just make a summary of what has transpired so far. We just conducted introduction of the audience as well as the high table, and we are calling upon everybody now to sit and we start our program. Sasa mwenyeji wetu kabisa katika shughuli hii ni mkurugenzi wa mradi wa HPSS ambaye ndiye ametuita na kutuambia njooni tuagane. Kwa hiyo tunaomba tuanze na yeye, tumkaribishe atoe maneno machache alafu tutaendelea na program. We invite the project director, Mr. Manfred, to address the guest of honor as well as the audience with a few remarks. Well, you're welcome.
Asante sana. Habari za asubuhi. So, Honorable Deputy Minister, the Honorable Ambassador, the Honorable Job Ndugai, the retired Speaker of Parliament, the Acting Permanent Secretary of Ministry of Health, representative of the Permanent Secretary of Pio Reich, Tamisemi, the representative of the Permanent Secretary for the Ministry of Community Development, other government officials from districts, from regions, also here, development partners and implementation partners, NGOs. Then ladies and gentlemen, so I welcome you all to this event from the side of the project in my function as a project director. We are now coming to a closure of the health promotion and system strengthening project, which has been active in Tanzania for 12 years. So 12 years ago, we had our first consultations with the Ministry of Health, with Tamisemi, with NHIF and other agencies on how to strengthen the health system. We are working over these 12 years in 4 components: on health financing, the reform of the community health funds, Then on medicine management with introduction of the Jazia Prime Vendor System. On health technology management, where we had some innovations also supported the government, and in health promotion. So in all these components, we worked very closely with the government. Actually, we did not implement anything in our philosophy, but we helped the government and supported the government with this Swiss funding from Swiss government to implement their programs and to improve their approaches with joint innovations and joint developments. We are proud now to have reached these 12 years, and I hope we can look back on some innovations, some developments which have been well integrated in the government structures and which are useful and helpful for the population of Tanzania. In the next 2 days, today and tomorrow, we will walk you through the different components we had, the different work areas, and try to summarize what we have reached and also discuss with the government the status of integration or the status of what the government is planning to do in the future. So I hope it will be 2 interesting days. So I just remain with welcoming you all to these 2 days and hand over back to our facilitator. Thank you very much.
Tunakushukuru sana Bwana Manfred kwa kutuadresi na kutupa background ya mradi na hatua ambayo tumefikia. Sasa tuko Dodoma. Dodoma ndio ilikuwa makao makuu ya mradi wetu wa Health Promotion and System Strengthening, lakini vile vile event hii inafanyika Dodoma. Kwa hiyo tunamkaribisha mwenyeji wetu Regional Administrative Secretary au katibu tawala wa mkoa wa Dodoma, naye aseme kitu kidogo na atukaribishe rasmi, atuhakikishie usalama wetu wakati tukiwa hapa. Karibu.
Ndugu mgeni rasmi, naibu waziri wetu wa afya Dr. Gordon Mollel, balozi wa Uswisi, kaimu katibu mkuu wizara ya afya na mwakilishi wa katibu mkuu ofisi ya Rais TAMISEMI na mkurugenzi wa mradi, makatibu tawala wa mikoa, makatibu tawala wasaidizi, wakuu wa taasisi mbalimbali wanaoshiriki kwa njia moja au nyingine kutekeleza huu mradi, pamoja na wanufaika, pamoja na watumishi wenzetu katika sekta ya afya, waandishi wa habari, mabibi na mabwana, habarini za asubuhi. Si bado ni asubuhi, bado ni asubuhi. Ninaitwa Dr. Besti Magoma, niko hapa kwa niaba ya katibu tawala wa mkoa. Mimi ni katibu tawala msaidizi wa section ya afya, ustawi wa jamii na lishe au mganga mkuu wa mkoa. Nipo hapa kwa niaba ya katibu tawala wa mkoa ambaye kimsingi alikusudia kuwepo leo, lakini tunavyofahamu changamoto za mkoa wetu wa Dodoma, kuna mambo mengi ambayo yanatokea kwa wakati mmoja ambayo yanaingiliana. Kwa aliniagiza, sio aliniomba, aliniagiza nije nishiriki kwa niaba yake. Kwa hiyo niko hapa kutoa salamu zake. Kama mkoa wa Dodoma tunashukuru kwa sababu huu mradi tumeushiriki kwa sehemu kubwa na tumekuwa wanufaika kwa njia moja au nyingine. Ninadhani inawezekana tumenufaika zaidi kuliko mikoa mingine. Kuna wakongwe ambao wameanza nao mradi. Nashukuru kuona Dr. Zainab Chaula yuko hapa. Nadhani ukimpa siku nzima anaweza kaeleza mengi mazuri ambao ameshayafanya, ambao sisi wengine tuliyakuta tukayarithi tukaendeleza. Kwa hiyo tunashukuru kwa ujio huu na ili kama mkoa unashukuru kwa kuamua kufanya hiki kikao cha kufunga mradi pale ambapo makao makuu ya mradi ulikuwepo na makao makuu ya nchi. Na tunaamini kwamba itakuwa ni kikao kizuri, na karibuni sana kwa niaba ya uongozi wote wa mkoa. Asanteni sana.
Nashukuru sana. Eleza kidogo kwa muktasari kwa Kiingereza ili kuwasaidia wenzetu ambao hawakuelewa mzungumzaji amesema nini, lakini kabla sijalifanya hilo, naomba nitumie muda huu kuomba radhi, lakini ninaomba niwasimamishe viongozi wetu kutambua uwepo wao. Naomba tuna maafisa utawala ambao wako ndani including Mama Chaula tunaomba tukusimamishe tena Mama Chaula na wengine wote waliomo muwaone. Yes. Tuna waganga wakuu wa mikoa, tafadhali tunaomba msimame. Asante. Tuna waganga wakuu wa wilaya, kama wapo tafadhali, popote pale ulipo simama, pungia mkono. DMOs. Okay, sawa. All right. So in brief, the representative from the representative from the Regional Administrative Office, RAS, for Dodoma, thanked everybody who has attended here, and with special thanks, she recognizes the contribution of everybody who managed to make the reality through this project to be true. And he said that Dodoma should be even more proud with the outcome of this project, because it was actually implemented in this region. And therefore, he's very honored on behalf of the region to welcome everybody in Dodoma. Kwa mujibu wa ratiba yetu, tunahitaji kupata maneno machache kutoka Wizara ya Afya, mwakilishi wa Wizara ya Afya, Katibu Mkuu. This is because kama mnavyofahamu, yes. Unataka kusema kitu? Naomba kumsimamisha dada Rehema Madenge. Mama yetu Mama Chaula anasema dada Rehema Madenge ndio alikuwa msimamizi mkuu kabisa wakati huo mradi unaanza. Kwa hiyo tunaomba kutambua uwepo wako. Utatusamehe, sisi wengine tunajifunza haya mambo ya kiprotokali, lakini it doesn't mean that we don't recognize your presence and your contribution. Sawa. Nilikuwa nasema kwamba 90% ya shughuli za health promotion and system strengthening ilikuwa ni afya, ingawa ilikuwa inafanya cut across other sectors. Kwa hiyo tunadhani ni muhimu kusikia kutoka kwa mdau namba 1 wa sekta ya afya. Kwa hiyo tunaomba tumkaribishe mwakilishi wa Katibu Mkuu Wizara ya Afya ili aseme machache kidogo kuhusiana na mradi huu, kama wao ndio wasimamizi wa sera na wenzetu wa TAMISEMI wakiwa ndio watekelezaji. Karibu.
Mheshimiwa Naibu Waziri wa Afya Dr. Godwin Mollel, ambaye pia ndio mgeni wetu rasmi, Excellency Ambassador Chasot Didier from Switzerland, we really acknowledge and appreciate your presence in front of us. Nitambue pia uwepo wa mwakilishi wa Naibu Katibu Mkuu wa TAMISEMI, dada yetu Subisia Kabuje. All staff from the Swiss Embassy, we also appreciate the presence of Swiss TPH staff from its leadership, as well as the HPSS project members who are here with us. Natambua pia uwepo wa makatibu tawala wa mikoa, wawakilishi wao pamoja na wasaidizi wao. Tunaomba tuwakaribishe sana. Tunatambua uwepo wa maofisa kutoka wizara mbalimbali, TAMISEMI, Wizara ya Afya na pengine. Lakini Mheshimiwa mgeni rasmi, niruhusu sana nitambue uwepo wa dada yetu kiongozi mwenzetu Dr. Zainab Chaula, aliyekuwa Katibu Mkuu wa Wizara ya Afya. Namtambua kwa sababu ndio utamaduni wetu wa Kiafrika, kwamba mtu akishakuwa mzee humvui koti lake. Huyu kwetu wengi amekuwa mwalimu mzuri sana na ametumenta wengi. Na siku zote si vibaya kusema mazuri aliyoyafanya mtu akiwa hai, ili wengine tujifunze na kuendelea pia kumtia moyo. Kwa hiyo Dr. Chaula, bado tunakutambua sana na mchango wako kwetu kutulea. Alikuwa anatulea vizuri sana. Kwa hiyo tutambue uwepo wako, pia involvement yako katika mradi huu na kusukuma kwamba uende mbele. Moja katika sifa yako ulikuwaga hutaki msamiati wa kushindwa, na tumejifunza kutoka kwako pia. Tunatambua pia uwepo wa staff from other development partners who are together here with us. Tutambue pia uwepo wa dada yetu Rehema Madenge, kama ilivyotamkwa kwamba alikuwa mwanzilishi wa mradi. Unajua muasisi siku zote ana siri nyingi sana za mahali, na pengine tutakwenda kusikia kutoka hapa. Mabibi na mabwana, habari za asubuhi. So I'm here to send you greetings from the Ministry of Health, in particular from the desk of our permanent secretary, who is out of Dodoma for other official duties. He had really sent a warm greetings to you, particularly congratulating you for your enormous efforts and contribution towards improving the health system in our country. So the Ministry of Health, as a sector ministry, is really privileged to receive support from the Swiss government in strengthening the health system in Tanzania through the HPSS project. This project has pioneered in many areas of the health system strengthening, which had led to a tremendous improvement of quality of health, as we are all aware that our ambition and our goal and the mission that we are trying to achieve right now at the sector ministry is the quality of health care that is provided to the population. So your support has improved the quality of health systems, and now it is more responsive to the health needs of our population. So we say asanteni sana for your generosity and your kind hand of support. So this project has greatly contributed to the government efforts to ensure that many and more of our population have access to health insurance services, as we have had a lot of efforts had been injected towards having ICHF, which really had saved a lot of lives of our population, because they were able to access the health services without being hindered by the cost of the services themselves. Together with that, we are also aware that your support through the project has strengthened the medicine supply and management through the vendor system, that when the medicines are not available through the official MSD system, the vendor system has really helped it to make sure that the medicines are available to serve and to be given to the needy. On top of that, we are also aware that this project has helped in the healthcare technical services, which are important as a parallel adjunct to delivering the quality health services. So not only that, but in the promotional sector, the project has helped to promote a lot of health and health-related activities to strengthen our health system. All these interventions have contributed in informing our government for policy making and decision making, as well as improving implementation of various strategies that have improved the health system in our country. We believe, as the Ministry of Health, as we are gathering here to conclude this project, we are aware that when you are doing a research, usually research unfold other weak areas that need further research. So the end of this project, we believe we must have learned a lot, and we have explored together the pitfalls or the weaknesses that need to be addressed. Therefore, it is the hope of the Ministry of Health that the end of this project may be the beginning of other projects that will fill the gaps that were identified during implementation of the ending project. As the ministry, we are willing to collaborate with the Swiss and any other partner who will come and knock our doors so that we can address together the challenges of our population. Having said so, I would like once again to thank you and welcome each and every one of us into Dodoma, and particularly the Ministry of Health, believing all the experience sharing that are going to happen here will help us to propel further the fruits and the benefits that we have all achieved together to cherish for the benefit of our people. Mungu awabariki sana, and thank you for your kind attention. Thank you.
Tunakushukuru sana Dr. Saitoti kwa very comprehensive address and summarizing the main focus of the project. Ni Saitori, sio Saitoti. Oh, samahani, Saitori. Sawa. He spoke in English for a greater part of his speech, and therefore nita summarize kipande kidogo tu kwa wazungumzaji wa Kiswahili. Alianza kwanza kwa kutambua uwepo wa viongozi wetu wawili wale ambao niliwasema mwanzoni, Mama Zainab Chaula pamoja na dada Rehema kwa michango yao mwanzoni mwa mradi huu. Lakini alijikita zaidi katika maelezo yake kuonyesha maeneo makuu ya mradi ambayo mradi imeisaidia sana serikali katika kuyafanya yaimarike. Alianza na eneo la CHF iliyoboreshwa na kuonyesha ni namna gani serikali imefaidika na shughuli zilizokuwa zimejikita katika eneo hilo. Katika kipengele vile vile cha health promotion, yani kufanya sensitization kwa wananchi waone umuhimu wa kutumia huduma, kutoa maoni na kadhalika. Lakini pia katika maeneo ya kidijitali kufanya mifumo yetu ya afya iweze kutekelezeka kirahisi na kutuhamisha kutoka kwenye paper based system kwenda kwenye mifumo ya kidijitali na kadhalika. Kwa hiyo kwa muktasari, ameushukuru mradi kwa mchango wake kwa serikali na kuonyesha namna ambavyo serikali ina appreciate hiyo. Sasa nitumie muda huu pia sasa kusema kwamba ilikuwa tupate remarks kidogo kutoka TAMISEMI, lakini katibu mkuu ofisi ya Rais TAMISEMI atakuja mwenyewe baadaye. Kwa hiyo mwakilishi wake ameomba asiseme chochote kwa sasa, atakapofika tutampa nafasi ili aweze kutuaddress. Kwa maana hiyo basi ninaomba nitumie muda huu kumnyanyua tena ndugu yetu Manfred kama mkurugenzi wa mradi wa HPSS, yeye atusaidie kumkaribisha balozi wa Switzerland ili naye aseme machache. Karibu bwana Manfred. Can you invite the ambassador to address the audience now? Yes.
So you see, I'm not only incapacitated in Kiswahili, but in many other areas, I'm afraid. There, I'm organized. Honorable Deputy Minister of Health, Dr. Godwin Mollel, distinguished participants at the high table, distinguished representatives of the Ministry of Health, the Ministry of Community Development, Gender, Women, and Special Groups, distinguished representatives of the President's Office for Regional Administration and Local Government Authorities, distinguished representatives of the Ministry of Finance, distinguished representative of regional and local authorities, distinguished representatives of NGOs, civil society organizations, development partners, media houses, dear colleagues, partners and friends, distinguished guests, mabibi na mabwana, habari za asubuhi. It is a privilege and a great pleasure for me to be here today for this closing workshop of the Swiss government-funded Health Promotion and System Strengthening Project, also known as HPSS. Distinguished representatives, dear participants, it has been a long way. Switzerland and Tanzania have a long history of mutually fruitful collaboration. The government of Switzerland has been supporting development projects in Tanzania since the early 60s. Activities intensified in 1981 when Tanzania became a priority country for official Swiss development assistance, and Switzerland opened a cooperation office in Dar es Salaam. This Swiss-Tanzanian partnership has had a number of remarkable achievements over the last 40 years. And today's event is one more key milestone that illustrates this close partnership. Indeed, today is a very special day, as it marks the climax of a 12 years long collaboration and engagement in the HPSS project with our partners from the Ministry of Health and from PORALC. In 2010, the HPSS project started modestly as a pilot in one region only, Dodoma. Upon request from the government, it was then scaled up to 2 additional regions, Morogoro and Shinyanga, in 2015. And finally, in 2018, the government started to roll out nationally the policy reforms that were piloted and brought by the project. Indeed, thanks to HPSS technical assistance, Tanzania has been able to strengthen its health system in 4 key areas: health financing, medicine supply and management, health technology management, and health promotion. All these components will be, of course, discussed in more details during this 2 days closing workshop. I was obviously not there when the project was designed and when it started and implemented throughout the first phases. When I arrived in Tanzania in 2020, however, the HPSS was the first health project of which I was made aware and for which I was solicited, as my arrival coincided with the signing of the bilateral agreement of the 3rd and last phase of the project. It is thus, in a way, a special project for me as well. To date, the Swiss government has invested over 42 million US dollars, equivalent to over 38 million Swiss francs, in strengthening Tanzanian health system through the HPSS. The project implementation has been guided by the basic principles of our international cooperation policy, which promotes systematic alignment, cooperation engagement, and support of our partners' countries' development plans. The HPSS has thus been fully in line with the health sector strategic plans of the Ministry of Health, the 5-year plans, development plans 2 and 3, and the Vision 2025. And the project, we firmly believe, has contributed to the country's sustainable human development based on the principle of social inclusion, participation, and accountability. Another important aspect of HPSS, also in line with Swiss international cooperation policy, has been that instead of directly implementing the project, Switzerland favored facilitating processes and providing technical assistance, thus enhancing capacities and expertise of Tanzania government counterparts throughout the entire project duration. Thanks to the scientific expertise of our project partner, the Swiss Tropical and Public Health Institute, a wealth of lessons learned and evidence could be generated from the 4 project components. In that way, enormous knowledge was transferred to government counterparts, leading to the development of many innovative and improved solutions to different systemic challenges of the health sector in Tanzania, but also surely for other countries around the world. Likewise, policy dialogue has taken place at and across all levels, central as well as subnational, leading to pioneering policy reviews and reforms. Today and tomorrow, during this closing workshop, we will hear in details of the achievements that have been made, the challenges that were faced, and how they were addressed to reach the overall goal of the project. The program for these 2 coming days is very comprehensive indeed, and I invite you all to take full advantage of the many avenues it provides for interaction. It is, by the way, very nice to see that some of the stakeholders who were at the very beginning of the project 12 years ago are here today to hear and exchange on the achievements of the HPSS project. Dear participants, before I conclude, I would like to recognize all the partners who have been engaged in this joint endeavor. In particular, I would like to acknowledge the strong leadership of the Tanzanian government counterparts, the Ministry of Health, the President's Office, Regional Administration and Local Government Authorities, PORALG, the Ministry of Finance, and the Ministry of Community Development, Gender, Women and Special Groups, without whose commitment, dedication and ownership to the project idea and implementation, we would not be here today. Of course, I acknowledge also the presence of civil society organizations, NGOs, research and academic institutions that worked closely with the HPSS project. Last but not least, let me also, of course, extend special thanks to the entire HPSS project team under the great management of Mr. Ali Kebi, as well as the Swiss Tropical and Public Health Institute under the leadership of Mr. Manfred Stürmer, for their essential role in building trust and achieving remarkable success. Dear all, the Embassy of Switzerland is very proud of this fruitful cooperation in strengthening Tanzania's health system. We are confident that the government of Tanzania will sustain this joint legacy and further build on it, especially in view of the envisioned universal health insurance. With the handing over of the different HPSS business processes going on, we wish the government of Tanzania all the successes and rest assured that Switzerland will continue its support to Tanzania in the health sector. I wish you all a good workshop. Asante sana kwa kunisikiliza.
Thank you very much, Honorable Ambassador, for a very nicely delivered speech and a very comprehensive one. Kwa muktasari tu kwa wale ambao si wazungumzaji wa lugha ya Kiingereza kabisa, Mheshimiwa Balozi wa Switzerland nchini Tanzania kwanza alianza hotuba yake kwanza kwa kushukuru kwa kuwepo hapa na kuainisha maeneo mbalimbali ambayo serikali ya Switzerland ina ushirikiano na serikali ya Jamhuri ya Muungano wa Tanzania, na alitujulisha kwa muktasari kwamba project ya HPSS ni safari ndefu ya kama tulivyosikia ni karibu miaka 12 imepita tangu mradi huu ulipokuwa umeanzishwa kwa mara ya kwanza, na kwamba wanajivunia kuona matokeo yaliyopatikana baada ya muda wote huu. Anasema wakati mradi unaanza yeye hakuwa balozi hapa Tanzania, alikuwa mwenzake, lakini alipofika, miongoni mwa shughuli nyingi za kusupport maendeleo nchini Tanzania, mradi wa HPSS ulikuwa ndio mradi wa kwanza kutambulishwa kwake. Naye aliupenda na aliweka jitihada kubwa kuhakikisha kwamba unatekelezwa. Na ametukumbusha pia kwamba mradi ulianza kidogo tu, ulianzia Dodoma kama pilot, lakini baadaye baada ya kuona kwamba mwelekeo wake ni mzuri, uliweza kuwa extended katika mikoa mingine ambayo pia aliitaja. na kutokana na mradi huu kuonyesha matokeo mazuri uliweza kuwa implemented katika phases mbalimbali, na baadaye ilipelekea serikali ya Switzerland pamoja na serikali ya Jamhuri ya Muungano wa Tanzania kuingia mkataba mkubwa kabisa wa kuhakikisha kwamba mradi unatekelezeka vizuri, na uli attract thamani ya karibu dola milioni 40 ili kuhakikisha mradi unakamilika kama ilivyotarajiwa. Amesema pia kwamba mradi huu una sifa moja kubwa, nayo ni kwamba uko very aligned, uko unafuata sana miongozo ya nchi. Kwa hiyo kwa hapa Tanzania mradi umezingatia vipaumbele vya nchi kama vilivyobainishwa katika nyaraka za serikali kama vile Health Sector Strategic Plan, Development Plan na miongozo mingine ya nchi. Lakini vile vile inaendana vizuri sana na sera ya nje ya nchi ya Switzerland ambayo inapenda sana kusupport process kuliko kusupport vitu vidogo vidogo. Kwa hiyo kwa muktasari, hayo ndio makubwa aliyosema, na alimalizia hotuba yake kwa kuwashukuru tena wote ambao mmeweza kuhudhuria hapa, lakini alitoa shukrani za pekee kwa taasisi ya Swiss TPH pamoja na taasisi zingine ambazo zilisimamia utekelezaji wa mradi huu, na aliwataja baadhi ya viongozi wa mradi huu kwa kipekee. Mwisho kabisa alituhakikishia kwamba ubalozi wa Switzerland hapa Tanzania unathamini ushirikiano uliopo na utahakikisha kwamba ushirikiano huu unadumu. This is just for a brief summary nilivyoweza kuyakamata na Kiingereza changu cha kindengereko. Sawa, sasa kwa mujibu wa ratiba yetu, kama kila kitu kingeenda sawa, hapa ndani tungekuwa na Mheshimiwa Waziri wa Afya pamoja na Mheshimiwa Naibu Waziri wa Afya wote kwa pamoja na kungekuwa na fursa ya Naibu Waziri kuzungumza. Tunaamini yale ambayo alikuwa ameyapanga tutamuomba ayachanganye pamoja na yale ambayo ameshauriana na Mheshimiwa Waziri kuja kutueleza. Kwa hiyo tunamuomba sasa, ingawa ratiba inaonyesha angesimama yeye, a hold kidogo. Tunaomba tutumie muda huu mfupi tuangalie ka video kafupi ambacho kanatupa overview ya what actually transpired kama introduction ya project ya health promotion and system strengthening. DJ.
A healthy, educated, and resilient population is a major prerequisite for every country to compete effectively in the global economy. It is in this regard that many countries, including Tanzania, have adopted a transformational health promotion approach. However, before the current changes, Tanzania's health promotion approach was traditionally top-down, where communities were treated as passive receivers of healthcare.
Kutokana na uchumi, ukaenda hospitali, ukifika pale mapokezi, bila 10,000 huwezi kusajiliwa.
Kabla ya huu mfumo kuanza, tukikosa vitendanishi MST baada ya kuoda,
tulikuwa tunakutana na changamoto ya upatikanaji wa taarifa sahihi za vifaa tiba.
Unakuta kifaa kinatupwa kwa sababu tu switch imekataa kuwaka.
With Tanzania increasing investments in healthcare to ensure universal access to quality health services for all citizens, the Swiss government was prompted to support this cause through the Swiss-Tanzania Cooperation Arrangement.
The HPSS is an ambitious project that was designed to support sector reforms so as to address access barriers to primary health services by poor rural populations. Moreover, and this is a key element in the current Swiss-Tanzanian cooperation program, HPSS contributes to strengthening the relevant state institutions so that they can deliver public health services more effectively, more efficiently, while being more and more transparent and fully responsive and accountable to the people's needs.
This partnership resulted in the birth of the Health Promotion and System Strengthening (HPSS) project, an initiative implemented by the Swiss Tropical and Public Health Institute that strives to improve the quality and utilization of health services in the country.
HPSS tumefanya nao kazi kwa kipindi cha miaka 12 sasa. Na HPSS ni matokeo ya ushirikiano baina ya serikali ya Tanzania na serikali ya Uswisi. Na HPSS ilivyoanza kutekeleza mradi wake wa uimarishaji wa mifumo ya afya Tanzania, ulikuwa ni kwa lengo la kuisaidia serikali ya Tanzania kuimarisha mifumo yake.
All in all, HPSS has proven to be a most valuable component of our partnership with the Tanzanian government to reform the health sector and to increase access and quality of health services for rural populations, leaving no one behind.
The HPSS project has helped to strengthen the health system of Tanzania in such areas as health financing, medicine supplies and management, health technology management, and community participatory health promotion. Furthermore, the project has supported the government of Tanzania in digital health and research.
So the approach of the project is a system strengthening approach. We're not concentrating on one individual field of activity, but rather would like to or try to strengthen the whole system in its interactions.
Our project from inception has aligned very much with the government priorities as stipulated in the various programs and strategies. So with that, we do apply some inclusion approaches to work with the government from the planning level to implementation level. So that has been our philosophy on working with the government in order to strengthen the health system in the 4 working areas that project has been supporting. In using various platforms that created by the project, but also existing in the government structure, to have a dialogue together to identify priorities and therefore develop interventions and implementation strategies.
So far, the HPSS project interventions have significantly contributed to improved health service delivery in Tanzania.
La kwanza ilikuwa ni swala zima la usimamizi wa mifumo ambayo itasaidia katika uchangiaji wa fedha na uchangiaji wa huduma ambayo utapelekea wananchi kuweza kuwa na nafuu katika uchangiaji wa huduma. Mfuko wa afya msingi ni moja msaada. Ya pili ilikuwa ni swala zima la huduma za upatikanaji wa dawa, vifaa na vifaa tiba. Na ya tatu ilikuwa ni swala la ukarabati na ukarabati wa vifaa na vifaa tiba kupitia component ambayo inaitwa Health Technology Management. Na ya 4 ilikuwa ni kufanya promotion ya masuala ya afya.
Empowerment of individuals and strengthening their actions for health is a crucial element in strengthening health promotion approaches at community, regional, and national levels.
Health promotion is a process that intends to empower individuals to take control over their health and well-being, as was informed by the situation analysis, which we conducted already in 2010 and in 2011. So this situation analysis has revealed that the health promotion practice then was more on a top-down approach with very minimal or no community empowerment, participation, and engagement.
Kuna umuhimu wa kupeleka huduma hii mashuleni, kwa sababu kwa hali ya kawaida kabisa huwa hatuna utamaduni wa kwenda kucheki afya mpaka tumeumwa. Lakini wataalamu wa afya wanapokuja mashuleni wanatusaidia kubaini hizo changamoto tulizonazo. Kwa mtoto anapopata huduma mapema inamsaidia pia, ataweza kuhudhuria masomo yake darasani vizuri na kwa wakati, na kwa maana hiyo tutainua taaluma, kwa sababu hata ufaulu wake utakuwa mzuri, tofauti atakapokuwa na changamoto akabaki nyumbani.
This initiative has been achieved at a low cost by a cascade of training and interventions in the villages through community participatory health promotion activities.
Health promotion katika miaka hivi karibuni, na kutokana na mabadiliko makubwa yanayotokea duniani na magonjwa mbalimbali ambayo yanajitokeza, ndio njia pekee ambayo inaweza kuwafanya jamii kuwa salama, kwa sababu inafikisha taarifa kwa haraka na mtu anakuwa na taarifa zote za namna ya kujikinga na madhara mbalimbali au magonjwa ambayo yapo kwenye ngazi ya jamii. Kwa mfano tulivyokuwa na COVID, tumekuwa na tishio ya magonjwa kama Ebola. Ndio magonjwa madogo madogo yanatokana kama milipuko, magonjwa ya kipindupindu na nini. Kwa hiyo watu wanakuwa wanafahamu yale magonjwa kupitia afua hii health promotion, namna ya kujikinga.
The cost of healthcare is a major financial burden on families. Millions of people spend at least 10% of their household budgets to pay for healthcare, often forcing them to choose between their health and other necessities.
Kutokana na uchumi, unaweza mtoto akaumwa ghafla, ukaenda hospitali, ukifika pale mapokezi bila 10,000 huwezi ukasajiliwa. Kwa hiyo pale utoe 10,000 kwanza ndio usajiliwe. Na ukiwa unaona kama huna bima, leo umeumwa baba, kesho na hali ya kiuchumi ni ngumu sasa hivi.
So from that situation onwards, we decided to support the government in the development of a full-fledged health insurance where people can get services all over the country, and also a benefit package which allows them to go to hospital services, higher level services in case of need.
To address these ever-increasing expenditures on healthcare costs, Tanzania's witnessed the introduction of health insurance. The government prepared a short-term plan to ensure that citizens, especially those in the informal sector, which constitutes a large percent of the total population, are covered by the Community Health Fund.
Maboresho ya mfuko wa afya ya jamii CHF yamekuja kwa malengo ya kuboresha huduma kwa mwanachama. Wanachama wake ni wananchi walio katika sekta isiyo rasmi, wakulima, wafanya biashara ndogo ndogo, kina mama ntilie, wachimbaji wa madini wadogo wadogo, wafugaji, vikundi vidogo vidogo vya ujasiriamali. Hawa ndio walengwa mfuko huu. Na hata ukiangalia kiwango kile wanachochangia, unaona kabisa ni kiwango pekee, ni kiwango kinachomwezesha kabisa mwananchi wa kawaida aweze kufikia mfuko huu, kwa sababu hawa ndio wana changamoto na wenye uhitaji wa huduma za afya.
The uniqueness of this social health scheme is that it provides different possibility for people in the Tanzania to access medical care. Whether you have high income, you are low income earner or mid income earner, this package provides a solution for you.
One important step was enrollment at the community level where people live, instead of having them travel long distances away from their communities for this purpose. CHF iliyoboreshwa has helped to make access to healthcare more equitable across the general population and reduce the burden of healthcare costs among the poor.
Afya ni mtaji na kila mwananchi ana haki ya kuwa na afya bora. Sasa moja ya njia iliyofanya ni kuhakikisha kwamba tunakuwa na mfuko wa afya jamii ambao unalenga sana wananchi ambao wapo katika sekta rasmi. Na kwa kufanya hivyo ni kwamba wananchi hawa wanaepukana na changamoto ya kutumia fedha za mfukoni pindi wanapokuwa wameugua. Badala yake wanatumia kadi na kupata matibabu haraka na kurejea katika shughuli za uzalishaji ambazo zasaidia kaya zao pamoja na taifa kwa ujumla.
The Medical Stores Department, MSD, is the backbone of the public medicine supply in Tanzania. However, MSD faces challenges in filling orders from health facilities. The supply gap of more than 40% stemming from the out-of-stock situation and low-order fulfillment needs to be complemented by medicines from other sources.
Tuko napata changamoto kubwa sana kipindi cha nyuma kabla zahanati haijafunguliwa. Sasa kwa watoto, kuta usiku mtoto anachemka anaumwa, itakulazimu utoke uende hospitali ya Mlenia. Kama daktari akakuandikiwa dawa, alafu anakuambia dawa hapa hamna, unaandikiwa uende kanunue mtaani. Mtaani kwenyewe wapi?
In partnership with committed and engaged local experts and authorities, and after lengthy discussions with all involved stakeholders, we piloted a public-private partnership model with pooled procurement from a prime vendor at regional level in Dodoma region.
We designed an innovation which is called Prime Vendor System, and by then in 2014, the design was having one vendor who supplies the whole region. It's called a Prime Vendor System with a single vendor with pooling all orders.
This complementary supply chain has significantly improved the availability of health commodities at all levels of the health system.
Kupitia mfumo huu unatuwezesha hata sisi kujipanga vizuri katika kustock mali, ili inapotokea tu MSD kuna upungufu, wanaporudi kwetu basi tuna uwezo wa kujazia kwa haraka na kwa kiasi ambacho kinahitajika.
Jazia Prime Vendor System now covers all 26 regions and covers over 8,000 health facilities.
Hapo awali tulikuwa tuna ujuzi wala uzoefu wa kutoa dawa, tulikuwa tunatoa tu dawa tu bila kufuata utaratibu. Kwa mpaka sasa hivi kwamba vituo vina uwezo wa kuagiza dawa kutokana na mahitaji ya kwao, na hivyo kupelekea upatikanaji wa dawa zote muhimu vituoni kwa muda wote.
When we started, the availability was 57%. After 4 years of implementation, significant increase to 92% in health facilities. There is a strong synergy in the introduction of Jazia Prime Vendor System.
Kwa sasa hivi kwa kweli huduma zimerahisishwa. Unaweza kaenda zahanati, ukapimwa, ukapewa dawa. Umuhimu wa upatikanaji dawa kwa kweli katika jamii ni jambo la muhimu sana katika vitu vyote.
The rapid deterioration of infrastructure and frequent equipment failures not only impairs medical services, but may pose a health hazard to patients and staff at the health facilities.
Hospitali nyingi zilikuwa zinatumia mafundi wa mtaani, local fundi, katika kufanya matengenezo ya vifaa tiba. Na challenge kubwa ambayo ilikuwa inatokea kwa hao mafundi, kwa sababu hawakuwa na ujuzi wa vifaa tiba, vifaa vingi vilikuwa vinafikia mahali vinatoa majibu ambayo sio sahihi, na ikapelekea tatizo la wagonjwa wengi kupewa ugonjwa ambao walikuwa hawana.
HTM, or what we call it health technology management, is an important aspect of the health system building block. So that's deal with the technology and also biomedical engineering field as a whole. Our project decided to invest in the health technology management in order to support the government health system after the situation analysis that we conducted in 2011. That has informed us in many aspects in terms of what are the gaps existing in the management of technology. So after that realization, therefore, we came to devise these interventions.
Through its Health Technology Management, HTM component, the Health Promotion and System Strengthening Project has developed some key innovations and anchored them into government policies for sustainable implementation.
HPSS in this intervention involved government at all levels to plan and devise interventions that will help to strengthening the health technology management. Through that approach, we were able to develop a system which were owned by the health system.
Mfumo huu umetusaidia sisi wataalamu wa vifaa tiba. Kwanza kuna sehemu ya kuweka lifespan ya kifaa, lakini pia mfumo unatunza rekodi ya kila kitu ambacho umekifanya kwenye kile kifaa.
On the digital health, HPSS has played a very big role to ensure that it gives support financially and technical support. And we've helped the government to develop a number of systems. And some of these systems include Insurance Management Information System, that IMIS. This is a system that supports the government to operationalize Community Health Fund, or CHF.
This initiative has contributed to an increase in human resources in the health sector.
IMIS is a web-based system, is a centralized system. So we have a central server that is hosted by the PORAG. It communicates with a mobile application. So the people at the village level, district up to regional level, they use mobile application to do the enrollment. It works in the mobile phone at the same time also on the web-based.
MEMIS ni mfumo wa kielektroniki ambao umejengwa kwa kushirikiana na HPSS pamoja na Wizara ya Afya. MEMIS inaweza kusaidia katika hatua mbalimbali za management, katika ngazi ya mtumiaji, ngazi ya utawala, katika kufanya maamuzi mbalimbali ya uwekezaji katika teknolojia mbalimbali za vifaa tiba.
HPSS has managed to improve primary healthcare services, especially preventive, affordability, and accessibility care. The project strengthened the management of medicines and health supplies and related services from 53% in October 2011 to over 90% in July 2019 in the pilot regions. Health promotion innovations, training packages, materials, tools and guidance documents will be scaled up nationally in all 26 regions and their 184 districts.
Well, as for me, I've been here for almost 12 and a half years since we started until now. I have seen things are changing. We started as a pilot. It wasn't an easy job, but we did and informed different people in a decision making in the government, and they are able to learn through the process together with us, do some evaluation. And now when we are talking, most of our intervention has been rolled out across the country. So that's made me very proud, and I'm very happy to be part of HPSS.
Regarding sustainability, it was important for the project from the beginning to work in an integrated way with the government. So we never operated a system on our own, like CHF or anything else. We always support the government in their operation and management of the systems. I think that's the most important thing regarding sustainability. Then, however, we make a lot of efforts now in the final phase of the project to make sure that capacities are in place, that all the systems are strengthened and integrated in the routine work of the government.
For the development of a country, the socio-economic development of a country, and especially a country like Tanzania with such a demographic explosion, one might say, health issues are really key and they should be considered as priority challenges. This is why we, Switzerland, we have included our health portfolio for a very long time, and we are partnering with the government in those issues.
Asante sana. Can we have lights on? Ilianza kama wazo, imekuja kugeuka kuwa kitu kikubwa. It's not a fictitious movie. This is a true story. It's a true story from a small idea to something very big, which we are all proud of today. Ndugu mgeni rasmi, tunakushukuru kwa muda wako na kushuhudia. Sisi wengine ni walimu, tunaamini kwamba learning is threefold. Ili uweze kujifunza, vitu vitatu lazima vitokee. Kwanza usikie, pili uone, alafu tatu utende. Na kwa hiyo basi nitumie fursa hii kukushukuru kwa sababu umeshuhudia haya yote, na nina uhakika you have learned kwamba hii project, najua umekuwa unapata ripoti katika siku za nyuma, lakini leo kile kipengele cha tatu cha kushuhudia na wewe mwenyewe kuona na kushiriki kimekamilika. It's a complete learning process. Ninaomba nimnyanyue kaka yangu Dr. Leiza tena atusaidie kumkaribisha mgeni rasmi, ili mgeni rasmi utupe machache ambayo ulikuwa umeandaa kutuelezea kabla hatuja kuruhusu, najua ratiba yako imebana sana, kabla hatuja kuruhusu kwa mambo mengine. Karibu Dr. Liza.
Mheshimiwa mgeni rasmi na naibu waziri wa afya Dr. Godwin Mollel, kazi yangu ni kutamka neno moja tu. Kwa heshima na taadhima, naomba nikukaribishe. Asante.
Bwana Yesu asifiwe. Tumsifu Yesu Kristo. Assalamu alaikum. Please clap the hand for our honorable ambassador, please. And also, please, also another clap for the people of Switzerland for the great contribution to our people. Can you? Yes. Thank you very much. We really appreciate what you are doing to our people. You've done a great job for these 12 years, but we have been working together bilaterally for more than 60 years, and you did a tremendous job to our people. We thank you a lot. We thank you a lot. And I really appreciate you said you'll be with us more. In basket fund, my sister was telling me about the basket fund and other issues. But also, I love the way you put it, said, now you're going to think of how we can work together through universal health coverage. And actually, that is what our minister, Honorable Umi Mwalimu, was asking. Before really you decide where are you going to, what area are you going to support, it will be very good you have discussion with her, and then we decide all together to see where are we going to work all together to make sure that Tanzanians are going to get more benefit out of it. And we thank you a lot. We thank you a lot. I salute you, my friend. But please allow me, because we have the guys from news and other things, I really need to know, I really wish that Tanzanians will know the great job you have done to our people. So I'm going to switch to Swahili. Are you allowing me? You allowing me, eh? Yeah, so that our people, Tanzanians, we know what are the impact of our relation, Tanzania and people of Switzerland. And I saw a very nice video showing all progress from where we started till now. I'm telling you, there is a great improvement, a lot of improvement. We witnessed for this all 12 years. I've seen a lot of changes. Thank you very much. Ndugu zangu, kwanza nawasalimu jamani. Asanteni kwa kazi kubwa ambayo mmeifanya. Inasikika eh? Kama vile mimi sisikii. Inasikika eh? Asanteni kwa kazi kubwa ambayo mmeifanya kupitia hii project. Lakini kaka yangu Mdengereko oye. Mdengereko kaniambia ilikuwa wepo Umi na mimi. Kwa hiyo niseme ya Umi alafu niseme yangu, lakini kusaidia tu Mdengereko hakuna ya Umi na ya kwangu. Hakuna ya Umi na ya kwangu. Na ile wizara ina waziri mmoja. Mimi ni subset yake, ni naibu wake. Kwa hiyo nitakachosema ndicho cha Umi. Na shukurani niliowapa wapendwa wangu ndio shukurani ya Umi. Lakini naposema dada yangu Chaula amefanya kazi nzuri, pia ndio Umi anaamini hivyo. Dada yangu Chaula ni dada yetu sisi tukiwa vijana wadogo, tulikuwa tunamwona, si ndio? Tukiwa shuleni tunaona mambo yake mazuri. Tunaona tunakuja tunakuwa wabunge, tunamkuta bado yuko. Mimi nimekuwa mbunge ukiwa naibu katibu mkuu TAMISEMI, si ndio? Tumekuona kazi zako, lakini mpaka sasa tunapitia dokumenti nyingi, tunaona saini zako. Tunakushukuru sana dadangu, tunakushukuru sana. Na kila mahali ambao tunapitia hatujaona udhaifu. Lakini nimeambiwa dada Madenge, asante sana dada Madenge kwa kazi mlioianzisha. Ila mmesahau kuna dada yetu dada Sawa. Si hamjamuona Sawa? Dada Sawa, simama basi tukuone. Eti nani hii? Dr. nani? Ongara, Dr. Ongara, si ndio? Kwa nani amkumbuki Dr. Ongara? Si ndio dada zetu wakati huo ni wanafunzi na nini? Tunaona shida kumfikia kina Chaula, tunabidi tumtafute Ongara. Kwa hiyo asanteni kwa kazi kubwa ambayo mmeifanya jamani. Asanteni sana. Tumeangalia klipu, tumeiona, tumeelewa. Na kikubwa sisi ukweli tumeona improvement. Ukiangalia toka tulikotoka tunaona improvement kubwa kwenye mifumo ya afya. Ila tunahitaji kuboresha zaidi, si ndio jamani? Tunahitaji kuboresha zaidi maeneo mengi. Na nafikiri kuna ideas nyingi zimeibuka hapa kama mshitiri. Anaitwa mshitiri Anaitwa mshitiri. Ukisikiliza vizuri ni jambo zuri sana jema. Ila tunahitaji pia wakati tunaenda mbele sasa tukaliboreshe zaidi, si ndio? Kwa sababu unaweza ukaweka jambo zuri lakini binadamu wakaweka ya kwao, si ndio? Yakatuletea shida. Lakini mimi naamini kwenye nimeona sehemu nyingi anachelewa msitiri, natokea hiki na hiki. Kwa hiyo hayo tunaweza tukarekebisha, lakini ukisikiliza lengo la walioanzisha ni zuri sana. Kwa hiyo mimi nawaomba tukayaangalie hayo na tuyaboreshe kwa pamoja. Lakini naomba jamani, kama tunaenda sasa kuendelea na wapendwa wetu, tutafakari kwa pamoja critically. Kama ni fedha basi tuende kuwekeza kwenye lile eneo ambalo tukihiti basi tunakuwa tumetatua matatizo ambayo yanatukabili. Tunakubaliana hilo na balozi amesema priority yao sasa hivi ni eneo la nini? Universal health coverage. Sasa tunapokwenda kuamua basi tukaamue kwa pamoja eneo ambalo wakitusaidia hilo eneo tunaenda kuona impact ambayo inaenda kugusa maisha ya watu. Pia kwa sababu anatuachia sasa vitu vingi, nafikiria hata kwenye health system na vitu vingine tushirikiane pia kwa pamoja, tuone ni namna gani tutaendelea kutoka hapa tulikofikia, tufikie mahali tuwe na mifumo ambayo inasomana. Tunayo sasa hivi mifumo inasomana? Eti Saitore, mifumo yetu inasomana? Haisomani. Kwa hiyo tuna pamoja tumetoka mbali, angalau kuna nafuu kuliko tulikotoka, lakini tunafanyaje sasa tutengeneze mifumo iliyosomana? Kwa sababu leo tuna teknolojia nyingi. Leo CT scan isirudiwe, isomane mifumo ya hospitali yetu kuanzia kituo cha afya mpaka hospitali yetu ya taifa. Mifumo yetu isomane na mifumo ya bima kama tunaenda kwenye universal health coverage, maana yake na mifumo yetu ya bima. Kwa maana ya kwamba kama ukipiga CT scan kwenye level ya mkoa, ukifika taifani kama hakuna sababu za kitabibu za kuirudia, ile iweze kutumika. Lakini vitu vyetu visomane. Tumetoka mbali lakini tunatakiwa tuone ni namna gani tunaboresha zaidi kutoka hapa ambapo tumefikia. Sijui kama naeleweka wapendwa wangu. Mnanielewa vizuri Yes, na mimi hayo ndio kwa kweli yanayotuumiza sisi vichwa. Lakini kama ukisikia ukweli ni kwamba ubora wa huduma tulikotoka na sasa ubora wetu wa huduma umeongezeka, umeimprove sana. Si tunakubaliana wote, si ndio? Lakini pia criteria yetu moja kubwa sasa hivi, jambo letu kubwa moja ni kuboresha huduma, na mmesikia ubora wa huduma. Sasa kuna indicators za ubora wa huduma. Tunaomba tulikofikia na tulikoanzia creative yenu kama hii nzuri ambao mmeifanya hapa iendelee pia kuelekea tunapoanza kwenda mbele, basi tuoneje kwamba tunaenda kuboresha huduma zetu, kwa sababu ukiangalia yote mnaangalia ni namna gani tunaweza tukaboresha huduma. Tungekuwa Tanzania wenyewe ningewaambia mengine, mnaniruhusu nisiseme mengine, si ndio? Lakini napataga shida. Kuna mengine hayako hivyo kama ilivyo pale kwenye ile kitu. Kwa hiyo angalieni mnapoenda kurusha, tuwe makini, kwa sababu sisi mimi sasa hivi nimeshakuwa mbogo, kwa sababu kwa sasa ninachokitaka ni kura za Dr. Samia Suluhu Hassan zijae. Chochote ambacho kinapunguza kura za Dr. Samia Suluhu Hassan mimi inaniletea tabu. Je, wewe inakuletea tabu? Wangapi inawaletea tabu? Wangapi inawaletea? Naona sio wote. Haki ya Mungu alai. Yesu Kristo. Naona sio wote. Lakini kwenye ilani ya Chama cha Mapinduzi tuliahidi kwamba tutaleta bima ya afya kwa wote. Si ndio? Na imeandikwa kwenye ilani ya chama na ilichaguliwa kikatiba. Manake wote sisi tulioko serikalini, tulioko nje ya serikali, tunatekeleza kwenda kufikia hayo. Wote kwa pamoja akili zetu zielekee sasa, asiwepo anayezungumzia tofauti na kilichopo cha ilani ya Chama cha Mapinduzi ambayo inasema twendeni tukaanzishe bima ya afya kwa wote. Tunaelewana jamani? Na balozi amesimama hapa, ameisoma vizuri, amesema na yeye sehemu ambayo anaenda kuelekea ni kwenye swala zima la bima ya afya kwa wote. Ninaeleweka jamani? Tunaelewana jamani? Unajua ubaya wa science, ukiskipu ukaweka ya kwako mbele inaenda kukuumbua, au uongo jamani? Ni sawa, kuna wilaya nikisoma dokumenti zake wameandika wamechanja 120%, wamechanja 140%, lakini kuna milipuko ya watoto kupata hiki na hiki, surua sijui nini, lakini ukienda kwenye document walichanja 140%. Sasa maana yake ni nini? Ni kwamba inawezekana data walioitumia mwanzoni kwamba ndio idadi ya watoto, au kuna sababu nyingine. Lakini ubaya wa kazi sisi tunayofanya, hasa sisi kwenye eneo la afya, na Chaula ni shahidi yangu, ukiskip tu chochote ya hakijanyoka namna hiyo kinaenda kukurudia. Kwa hiyo ndugu zangu, sina mengi ya kusema zaidi ya kuwashukuru. Nashukuru kaka umeniekea hiyo nini naitwa hiyo ya kuangalia hiyo. Tumeelewa vitu vingi sana, imetufundisha. Kuna vitu vingine hata mimi nilikuwa sijajua yanaenda kwa direction hiyo, nimejua. Lakini kwa kweli mmefanya kazi kubwa sana. Mmefanya kazi kubwa sana. Na nataka kuambia hata kama ufanye kubwa sana, wakati mwingine huwezi kumaliza matatizo, na hakuna atakayemaliza yote, si ndio jamani? Kikubwa sisi na ujumbe wa waziri wetu wa afya amesema niwatie moyo, endeleeni kutafakari kwa niaba yetu. Lakini sio tu waziri wa afya, hata leo nilikuwa naongea na waziri wa TAMISEMI asubuhi kabla sijaja, na yeye anawasalimia, lakini anawaambia asanteni sana. Mheshimiwa Mchengerwa anasema asanteni sana, na anapongeza kazi kubwa mnayoifanya. Tuendelee wote kwa pamoja kuongeza juhudi kwenye kufanya hilo, si ndio jamani? Mnatusaidia sisi, na mkitusaidia sisi mambo yetu yanakuwa mazuri, si ndio? Mnaniruhusu na mimi, kuna rafiki yangu anaitwa Nyamwela. Huyu jamaa kipindi fulani alikuwa ananitetea mahali. Hebu mpigieni makofi Nyamwela. Nilikuwa naye kwenye mapambano 2020 akawekwa ndani kwa ajili yangu. Unakumbuka ulivyopigwa ndani jamaa wangu? Ni masaa mangapi aisee? Kwa hiyo asante sana. Sina sehemu ya kukushukuru zaidi, au nafikiri nilisahau jamaa wangu ulifungwa kwa ajili yangu. Kwa hiyo Nyamwela asante sana. Ndugu zangu, sina ya kusema. Klipu yenu imeelezea vizuri. Saitore amesema mengi mazuri sana. Zaidi sisi tuwashukuru nyie ambao mnaifanya hii kazi. Nimeleta shukurani za kwangu, nimeleta shukurani za Mheshimiwa Umi Mwalimu, lakini nimeleta shukurani za Mheshimiwa Mchengerwa. Anawaambia asanteni sana. Si ndio jamani eh? Kikubwa tuondoke na energy mpya, mkawasaidie hawa mawaziri wetu ili kile ambacho rais anategemea kupata kwao kipatikane. Tunawapenda sana. Asanteni sana, Mungu awabariki. Asanteni sana.
Tunakushukuru sana naibu waziri ambaye pia ni mgeni wetu rasmi kwa siku ya leo kwa maneno mazuri, maneno ya ubaba ya kuhakikisha kwamba wakati kila mtu anatazama kwa jicho moja, wewe kama mlezi unatazama baadhi ya mambo kwa jicho la pili kuhakikisha kwamba hatujisahau. Niseme kwa muktasari tu kwa wale ambao hawakuisikia hotuba ya Mheshimiwa Waziri alipokuwa akitumia Kiswahili. Sehemu ya kwanza alizungumza kwa Kiingereza, kwa hiyo sitairudia. Yes. Nitakwenda katika mambo machache ambayo mimi ni kwa upande wangu niliona kama ni muhimu sana. Of course alianza kwanza kwa acknowledge kazi nzuri ambayo project imefanya, na ameadmit kwamba kadri siku zinavyozidi kwenda anazidi kujifunza. Kwa kuangalia video hii kwa mfano leo ameweza kujifunza vitu vingi zaidi, lakini ametukumbusha kwamba am I speaking in Swahili again? I was supposed to speak in English, si ndio? Yeah, the other language. I'm sorry. So for the non-Swahili speakers, I will just bring it a quick summary of what the guest of honor addressed us with. Yes. So he continued to acknowledge the project for his contribution, but he alerted us to look at the achievement with what the achievement come with, particularly some of the gaps that have already started to register. And we use this time, for example, the 2 days to critically reflect on these issues. For example, on the subject of prime vendors, there are some early learning that has been registered, and we have a room for improvement if we come with the resolution as we critically think. He also called upon everybody towards what he called integrated health system to ensure that it has synergies with other systems, because this is the big problem. Some of these innovations in terms of improving the health systems have been designed and developed in isolation. So one of the biggest challenges that the ministry is facing currently is synergy of different systems so that they can speak with each other. And he gave an example. If we are able to bring synergy to different systems, then there's no need, for example, if a medical examination is conducted in one hospital, to be repeated if the medical requirement does not require for a repeating examination. Experts can use the system to track records of the patients when they move at different levels. He also called upon improvement of quality of our healthcare, but he acknowledged that the project has contributed to improving the quality of healthcare in Tanzania. However, he had everybody to make to look specifically on issues that are very important, and he said there are some specific indicators that the government is really keen on to track in order to really speak with confidence that we have improved the quality. He doesn't deny that the project has improved quality, but he still thinks that there are areas that require further quality improvement. And he had us to still take time to reflect on everything that is the project has prepared in documenting its milestone when we are conducting this 2-day workshop. And he concluded his speech by sending regards on behalf of the minister herself, as well as the minister for President Office, TAMISEMI. I think that is just in summary of what he wanted to address to us. Asanteni sana. Ninaomba sasa niwashukuru watu wote ambao asante sana. Kwa hiyo tutawashukuru watu wote ambao mmekuwepo hapa kwa muda wote kwa utulivu mkubwa, na hasa wale ambao walikuja mapema sana asubuhi. Ratiba yetu ilikuwa imepanga saa 4 kamili tunywe chai, lakini mmeweza kuvumilia. Kwa hiyo tunaomba sasa tuitikie wito wa asili, tulitumikie tumbo kidogo. Tutaomba tuteremke chini, kuna staftahi imeandaliwa na kuna hapana. Kwa nini sasa mliweka hotuba yake? Na yake ilibidi vitu tufanye hotuba na okay, sawa. Kwa hiyo tunaomba tutapata maelekezo. Kuna vijana wameandaliwa kwa ajili ya kutuongoza kwenda kunywa chai katika maeneo mbalimbali. Tumetenga meza nyingi, sio kwa ajili ya madaraja yetu, hapana. Sisi wote hapa ni wadau. Tumetenga ili kwa ajili ya wepesi wa kukimbia na muda. Kwa hiyo mtapata maelekezo, wewe nenda pale, wewe nenda pale. Tunaomba sana tuwasikilize vijana ambao wameandaliwa wakituelekeza, ili ili zoezi liwe la haraka sana. Jana walikuwa wananiuliza, unadhani nusu saa inatosha kwa chai? Nikawaambia kama tuna watu 200 na kila mtu mmoja akihudumiwa kwa dakika moja, tunahitaji dakika 200 ili kupata chai. So we really need to be very creative how we can reduce the time within half an hour, kila mtu awe amekula. Sasa mgeni rasmi, tunafahamu kwamba utakapojumuika na sisi kwenda kwenye breakfast, if it is still breakfast, hautarudi tena hapa ndani. Tunaomba tutumie dakika chache. Tuliandaa zawadi kwa baadhi ya watu ambao wametusaidia sana kuhakikisha malengo na utekelezaji wa mradi huu hauanguki. Everybody has done something to make this project a success, but we need to recognize a few people ambao kutokana na contribution yao ndio maana leo tuko hapa tukicelebrate a ceremonial closure of the project. Kwa hiyo ninaomba nimkaribishe kaka yangu Ali Kebi, yeye ndio ataongoza katika swala hilo, lakini tunataka uwepo wako mgeni rasmi kwa sababu wewe ndio utakaokabidhi hizo zawadi kwa watu ambao tutawataja. Ali?
Asante sana Suleiman. Mheshimiwa Waziri, kwa ruksa yako tunaomba tufanye zoezi la kukabidhi zawadi ambazo zina lengo la kutambua mchango wa watu mbalimbali ambao tumeshirikiana nao katika utekelezaji wa shughuli za mradi wetu wa HPSS. Tumefanya kazi na watu wengi sana, lakini kwa kuwa hatuwezi kumpa kila mtu chochote kile kinachoshikika, naomba pia nichukue nafasi hii kwa niaba ya management ya mradi kusema tunawashukuru sana wadau wetu wote ambao tumeshirikiana, na kwa kipekee tutaomba uwakilishi kwa uchache kwa taasisi, lakini vile vile kwa baadhi ya watu mmoja mmoja ambao tumeweza kushirikiana nao. I was saying that what I'm going to do now just to lead a very simple process to honor some of our colleagues. We have worked together throughout the period of this project, including also the government institution present here, in a way that we show our appreciation of their support in implementation of this project. So we'll be calling names, and when you call the name of your institution, please, the representative should come forward and receive the award from the guest of honor. Asanteni sana. Na tutaanza, na ukisikia jina tafadhali naomba ukaribie. Nitaomba kwanza kutaja taasisi, alafu baadaye tutaenda kwenye orodha ya individuals. I will mention names, so you just get notices and prepare yourself. Wizara ya Afya naomba mjiandae. PORAG pia, Wizara ya Fedha, PPRA, Mamlaka ya Ununuzi wa Umma, Chuo Kikuu Dodoma, Chuo Kikuu cha St. John's Dodoma, taasisi ya afya Mvumi na wawakilishi wa Farm Access. Nafahamu Farm Access wameomba udhuru, naomba Kuki utapokea kwa niaba ya Farm Access. Baada ya hapo nitaita majina ya baadhi ya watu akiwepo mwakilishi wa wizara kutoka kwa Dr. Gwajima tafadhali, lakini pia Dr. Magembe kutoka Wizara ya Afya na Dr. Chaula na Dr. Ntuli Kaporoge na majina mengine yatafuata. Naomba tuanze. Wizara ya Afya. Wakati Wizara ya Afya anapokea, naomba makofi. Ofisi ya Rais TAMISEMI nayo watapokea. Naomba ifunguliwe. Asante sana, makofi. Ofisi ya Rais TAMISEMI. Wizara ya Fedha pia naomba tujiandae. Makofi mengi kwa TAMISEMI. Naomba arudie hilo zoezi muhimu sana. Wizara ya Afya wanapokea kwa mara ya pili, ndio wenye sekta. Asante sana. Wizara ya Fedha, mwakilishi Wizara ya Fedha. Kama wapo naomba ichukuliwe na mwakilishi HPSS. Huyu anapokea kwa niaba, atoki Wizara ya Fedha. Mamlaka ya Ununuzi wa Umma PPRA. PPRA. Yupo tayari. Asante sana. Naomba University of Dodoma. University of Dodoma, Dr. Kibusi. Dr. Kibusi tafadhali kutoka University of Dodoma. Wakati Dr. Kibusi anakuja, naomba St. John's University mwakilishi. Makofi mengi. Mheshimiwa Waziri, UDOM tunafanya nao program ya mafunzo ya health promotion kupitia chuo cha afya, na Dr. Kibusi ni kiongozi wa chuo cha public health. St. John's University. Hasa naomba tualike Mvumi, taasisi ya afya Mvumi. St. John's. Asante sana. Taasisi ya afya Mvumi. Naomba Farm Access, Kuki naomba wakilisha Farm Access. Baada ya utambuzi wa taasisi Farm Access, no. Makofi kwa Farm Access. Naomba sasa kipekee tuende kukabidhi zawadi kwa viongozi ambao tumekuwa sehemu ya shughuli hizi. Tutaomba kwa niaba ipokelewe zawadi ya Dr. Dorothy Gwajima. Bahati mbaya ameomba hudhuru, hataweza kushiriki, yuko Dar es Salaam. Naomba tuipokee, tutamfikishia ofisini. Huyu yeye anawakilisha taasisi nyingi kweli leo. Tunaomba pia Wizara ya Afya ipokee kwa niaba ya Dr. Grace Magembe. Fatma. Dr. Grace Magembe, naibu katibu mkuu Wizara ya Afya. Vile vile naomba sasa, wakati Fatma anapokea zawadi hiyo, naomba pia tumkabidhi zawadi mama yetu Dr. Zainab Chaula. Karibu, asante sana. Na kipekee pia naomba tumkabidhi pia zawadi katibu Dr. Chaula anakuja. Makofi tafadhali. Tumkabidhi pia mama yetu Dr. tumekuita leo Dr. Rehema Magembe. Pia tunathamini mchango wako. Madenge, nisamee sana mama, sio kanipiga makofi. Utamwambia jina lake tutabadilisha. Mpe ashike pale. Naomba pia Mheshimiwa Waziri uweze kusaidia kukabidhi zawadi kwa wenzetu. Ndugu Dennis Mbepera kutoka Wizara ya Afya. Naomba Dennis tafadhali. Wakati Dennis anakuja, nitaomba Fatma utiandae kuipokea zawadi kwa niaba. Wazunda. Naomba sasa tupokee zawadi, ukabidhi zawadi kwa ndugu yetu Rusajo Ndagile. Atakuja kumaliza kupokea kwa niaba. Asante sana. Wakati hilo linafanyika, naomba Yasin Kisawiki akaribia. Asante sana. Yasin Kisawike kutoka ofisi ya mkoa wa Dar es Salaam. Wakati huo naomba Dr. Lomwad Mbwasi, Dr. Mbwasi na Dr. Kasare tafadhali. Dr. Kasale, Harun Kasale. Mbwasi ndio anayotangulia, Mheshimiwa Waziri. Hiyo nani? Naomba pia umkabidhi Dr. Harun Kasale. Naomba Engineer Suniva Aule. Engineer Suniva. Asante sana, makofi. Naomba pia kipekee kabisa, baada ya zoezi hile umkabidhi mzee wetu Profesa Manolis Meshak. Makofi mengi kwake. Mheshimiwa Naibu Waziri, Profesa Meshak ndio alikuwa kiongozi mwanzilishi wa project yetu ya HPSS. amehudumu kwa miaka 8 na sisi. Namwomba pia nimuite ndugu Eliaki Yusuf. Eliaki Yusuf, tafadhali haraka haraka. Wakati Eliaki anapokea ya kwake, naomba Profesa Jeremiah Seni. Profesa Seni, tafadhali. Mheshimiwa Naibu Waziri, Profesa Seni amekuwa msaada mkubwa katika tafiti za mradi kwenye eneo la masuala ya matumizi ya dawa. Naomba pia utambue mchango na kukabidhi zawadi kwa Engineer Suniva Haule. Naomba Suniva upokee kwa niaba. Asante sana. Mheshimiwa, pia naomba kipekee tumkabidhi zawadi kwa kutambua mchango wake Dr. Deo Mtasiwa, hakuweza kufika hapa. Naomba mwakilishi apokee kwa niaba, aliandaliwa. See, are you supposed to be on that side? Aidha, tunaomba pia uweze kukabidhi zawadi kwa Dr. Ezekiel Mpuya. Dr. Ezekiel Mpuya amekuwa RMO kwa miaka mingi kwenye mikoa mbalimbali nchini na amekuwa mshauri kwenye mradi wetu wa HPSS. Makofi. Naomba sasa tukabidhi zawadi kwa ndugu yetu Amiri Muhando kutoka ofisi ya Rais TAMISEMI. Na akifuatiwa na ndugu Matthew Mganga kutoka ofisi ya Rais TAMISEMI. Na vile vile ndugu Zuberi Abdalla. Zuberi kama hayupo naomba pia ni muite na tumtambue ndugu Alpha Cholobi. Vile vile naomba tutambue ndugu Profesa Valence Ndesando kutoka St. John's University. Profesa Ndesando kama hayupo tapokelewa kwa niaba. Vile naomba sasa pia tukabidhi kwa ndugu Habiba Thabit. Mheshimiwa Naibu Waziri huyu hajafika bado. Ilete huko. Pia Dr. Ibenzi ametambuliwa lakini kwa bahati mbaya hajafika. Naomba tumpokelee Dr. Ernest Ibenzi. Mwajabu. Na vile vile tunaomba kutambua mchango wa Marco Salingu kutoka Wizara ya Afya. Aidha, tunaomba kutambua mchango wa Dr. Harun Machibia. Dr. Machibia tumefahamishwa yuko njiani anakuja, kwa hiyo tutamkabidhi baadaye. Naomba pia tutambue mchango wa ndugu Francis Rutalala. Dr. Francis Rutalala. Machibia anapokelewa na Mwajabu Machibia. Tunaomba tutambue mchango wa Dr. Rutalala Francis. Pia tunaomba tutambue mchango wa Elesia Mtesigwa kutoka ofisi ya mkoa wa Morogoro. Tunaomba pia kutambua mchango wa dada yetu Emiliana Francis kutoka Wizara ya Afya. Emiliana takabidhiwa. Tunaomba tumtambue pia mchango wa Cornel Mbele. Tunaomba Hamisi aje apokee kwa niaba kutoka ofisi ya Rais TAMISEMI, idara ya mifumo. Tutaomba pia wa acknowledge kazi ya Dr. Kelvin Mtavangu, bahati mbaya hajaweza kuhudhuria. Na pia ndugu Isaac Kaneno kutoka Wizara ya Afya. Na ndugu Raymond Kiwesa kutoka ofisi ya Rais TAMISEMI. Ofisi ya Rais TAMISEMI, tafadhali Amili, naomba tusaidie kumpokelea Kiwesa. Na pia tunaomba tutambue mchango wa ndugu Peter Ngalia. Tunaomba Hamisi umpokelee Peter Ngalia kutoka ofisi ya Rais TAMISEMI. Na pia tutambue mchango wa Umi wa Yayu kutoka ofisi ya Rais TAMISEMI, DLG Finance. Na vile vile kutambua mchango wa ndugu Kelvin Msovera kutoka Local Government Songea, lakini naye hajafika. Mheshimiwa, kwa niaba ya uongozi naomba nikushukuru kwa zoezi hili, na tunawapongeza sana wote ambao wameweza kutambuliwa mchango wao na wote ambao wameshirikiana nasi katika utekelezaji wa shughuli hizi za mradi. Asanteni sana, tunashukuru sana.
Mgeni rasmi, tunashukuru tena kwa kuendelea kutuvumilia na kutumia muda wako katika kutoa zawadi hizi. Kwetu sisi hili ni tukio muhimu sana, kwa sababu linaonyesha namna ambavyo tunashukuru na kurecognize specific contribution kutoka kwa baadhi yetu. Tungeweza kuona zawadi ya Ali Kebi hapa, lakini hakuna hata moja kwa sababu yeye alikuwa anatekeleza wajibu wake, lakini kuna wengine walifanya zaidi ya wajibu kutokana na uzalendo wa nchi na kuhakikisha kwamba mambo yanakwenda. Kwa hiyo tunashukuru sana kwa hilo. Mimi nimelelewa katika maisha ya participatory approaches, na ninaweza kusema ingawa zawadi sikupewa hapa, nilitegemea labda jina moja litakuwa langu. Wakati tunaanza mradi huu nilipewa kazi ya kufanya baseline assessment na situation analysis, kuangalia je, mradi huu unaweza ukatekelezeka na kama kuna mambo ya kuzingatia, vitu gani vifanyike. Na moja kati ya recommendation kubwa ambayo niliitoa ilikuwa ni kuhakikisha kwamba mradi utekelezwe kwa kufuata approach ya participation, na wenzetu wamefanya hivyo kuanzia mwanzo mpaka mwisho. Kwa sababu nimelelewa hivyo na kuamini hivyo, ninaomba niendeshe zoezi la participatory hapa tena la kuamua saa hizi tukanywe chai pamoja na lunch au tukanywe chai peke yake alafu lunch tule baadaye. Nitajadiliana na wenzangu wakati tunateremka hapo chini. Niliahidi asubuhi kwamba nitaelezea kidogo kuhusu logistics. Logistics muhimu ni maliwatoni. Ukitoka katika huo mlango tulioingilia, kuna sehemu ya kwanza ya maliwato iko wanaume na wanawake, lakini vile vile tunapokwenda kule chini downstairs ziko sehemu zingine ambazo tunatazitumia. Kwa sasa nadhani hilo ni muhimu, na kama nilivyosema, kuna vijana wameandaliwa watatuonyesha wapi pa kukaa ili tuweze kupata breakfast. Don't be surprised if you sit on a table having breakfast, your lunch plate is also brought to you depending on how ready they are, because we really need to catch up time. Saa hizi ni saa ngapi wenye saa? Saa 7. So we provide half an hour for breakfast, lakini it can turn up to 1 hour iwapo tutaamua kupata na lunch kabisa. So we are looking ahead to us coming back here either saa 7:30 au saa 8 kamili. We shall confirm as you are taking a breakfast. Tunaomba nikunyanyue sasa mgeni rasmi, utangulie na meza kuu kuelekea kwenye breakfast. Naomba wengine tusimame wakati mgeni rasmi ananyanyuka. Samahani kwa sababu hatutarudi tena hapa na tunataka hii background, tunamsumbua tena mgeni rasmi, tupige picha ya pamoja dakika chache. Okay, so we shall have 3 groups watu ambao tutapiga picha na mgeni rasmi. Nimesema tutapiga picha maana yake nami nitakuwemo. Ngoja nione kama nitaqualify. So the first photo taking itakuwa itashirikisha wenzetu kutoka embassy, watapiga picha na mgeni rasmi. Alafu yes. Alafu picha ya pili itakuwa ni management ya mradi, HPSS management. Picha ya tatu itakuwa ni viongozi wetu, marasi, RMO. Alafu kwa hiyo akina Dr. Chaula mtaingia katika hilo kundi la tatu. Development partners tungeomba muwe katika picha ya kwanza. Implementing partner, the development partners muwe kwenye picha ya kwanza, mkae na wenzetu kutoka embassy. So we invite DPs and IPs and the embassy to take the first photo with our guest of honor. Wakati wao wanafanya, kundi la pili, management ya HPSS project, get ready for that. Alafu tutamaliza management ya HPSS muwe wa mwisho. Picha ya pili iwe ni maras pamoja na viongozi wetu wengine, RMOs na kadhalika. Please, let's do that. Nani anasimamia mpiga picha mkuu yuko wapi? Tuwapange viongozi, maana kupiga picha ni professional. We usually respect every profession. Otherwise inaweza ikawa picha lakini isiwe picha. Please. Can we hurry up, please? Kama kuna kiongozi kutoka community development, iwe ni picha ya tatu sasa. Tafadhali viongozi wengine wote waliobakia kutoka Wizara ya Afya, kina Fatma na kadhalika, tafadhali. Wizara ya Afya, TAMISEMI pamoja na community development. Wakati viongozi wetu kutoka wizara hizi tatu wanakuja mbele kupiga picha na mgeni rasmi, management ya HPSS kaeni tayari. Na katika picha hiyo ya management ya HPSS tunaomba Dr. Kasale Profesa Meshak muingie katika management hiyo. Na Dr. Mbwasi tafadhali. Dr. Mbwasi, Dr. Kasale pamoja na Profesa Meshak mtakuja katika picha ya mwisho. Tayari mwatangazie kama tamana hizi picha zenu za siku hizi unapigwa picha hata hujui kaa tayari. Kwa hiyo tunaomba management ya HPSS mje mbele sasa. Tunaomba kumnyanyua pia Dr. Mpuya katika kundi hili, Dr. Kasale, Dr. Mbwasi na yes, na nani? Jiri na Hiren, please. Na nyinyi mjiunge katika, please can you join into this photo group? I thought the young one would be fighting to stand by the side of Professor Meshak so that they become successful as he was. But they keep distance from him. Maybe they are so much scared of gray hair. Great. Done? Asanteni sana. Kwa hiyo tunaomba tena tusimame wakati mgeni rasmi ananyanyuka na kutuongoza kwenda katika breakfast au brunch as they call it sometimes. Quick minutes yote tuongee nje. Tutavuruga utaratibu wao. So you don't have to carry your property. You can leave behind. We will take care of everything in this room. Tunaomba tuhimizane. Kama una simu ya rafiki yako ambayo yuko huko chini bado anakula, mpigie arudi hapa ukumbini tuendelee. Kuki, ingia ndani tafadhali, usitoke nje. Naomba tuhimizane kurudi ndani tafadhali. Ali Kebi, kama kuna watu naomba wahimize waingie ndani. Nilikuwa na kuhimiza kama kuna watu kule kwa corridor waambie waingie. Hii kelele sio toka. Wale walikuwa wananiambia sijui maiki mbili zimefunguliwa. Hamna maiki mbili. Hi, good afternoon. So let's resume our program. We expected to use 1 hour from now until 3 p.m. and we shall have 5 speakers. This is a continuation of the morning program. It was supposed to happen in the morning, but as we all know now, that we couldn't do that. We have heard many times that Honorable Madam Chaula her name is being mentioned several times, and this is because of her role and the contribution to the project in the virtue of her position at different times. So we thought we could give her a few minutes, 5 maximum, to say something so that we, beyond what we have awarded her, we can still benefit from her wisdom. So I would like you to call upon Dada Zainab Chaula, if you can come to the stage, and we hear your voice, which we are missing it very much nowadays, once again, and we learn from you.
Assalamu alaikum. Tumsifu Yesu Kristo. Awali ya yote naomba tumshukuru Mwenyezi Mungu, mwingi wa rehema na mkarimu, kwa kutukutanisha siku ya leo. Naomba nichukue nafasi hii kuwashukuru wote. Naona Mheshimiwa Balozi ameondoka, naibu waziri, lakini mshukuru sana Manfred, namuona hapo Dr. Karin na entire team ya TPH Swiss. Kina dada Jacqueline, tumekibizana hapa na pale, lakini shukrani za pekee Profesa Meshak ambaye ndo alikuwa meneja mradi, ambaye sasa amwachia Ali Kebi, dada Fiona na wote ambao nikiwataja hawaishi kwa sababu imekuwa dakika 5. Labda mimi nataka kusema nini? Ya kusema ni mengi, hata mkanieka hapa wiki nzima hayaishi. Lakini tu itoshe kupitia documentary ambayo ilionyeshwa hapa, tuliona. Lakini mimi nimechukua hichi kitabu ambao cha 12 years of Swiss Tanzania cooperation. Mafanikio na success stories zote zimo humu ndani. Mimi kama Dr. Zainab Chaula ambaye ni daktari, nikisimama nikiwa na mama Rehema Madenge huwa nafurahi sana. Yaani kama sifa na utukufu ni wa Mwenyezi Mungu. Lakini Rasi naye ni mlezi wa pekee kwa sababu alinilea. Yaani kila kitu kizuri kikitokea alitamani niwepo kwa sababu mimi sifa moja tu ninayo. Sitamani kufeli na wala sitakani feli. Kwa sababu naamini katika team spirit. Kwa hiyo ukiteuliwa manake una watu. Kwa hiyo hizi sifa na utukufu wote ni wa kwetu. Kwa sababu success story not for an individual but for an institution and system. Kwa hiyo wenzetu wa Swiss kwa maana ya health promotion ni wametusaidia kuweka mifumo ilikuwepo lakini ilikuwa weak. Wakafanya analysis zao, akaja na vitu vyao with clear vision, objective, target, activities, na zote tumeweza kufanikiwa kwa sababu ya mashirikiano. Kwa hiyo wamepoteza muda wao in term of funds, in term of technical support, lakini team spirit. Kwa kweli nikivuta picha 2011 wamekuja na mambo yao mazuri tu, lakini wametushirikisha, wametuona madhaifu yetu, akaje kwa upendo tu. Kwa hiyo sisi tulichofanya ni kukubali na kushirikiana nao na kutoa yale ambao maoni ambayo tulikuwa tunafikiri yatasaidia, na amesaidia kutoka kwenye pilot project mpaka kwenye full funded, yani program ambao mpaka miaka 10 tunasherekea hapa, si jambo dogo. Naomba tuwapongeze. Wamezungumzia 4 components, sitaki kuzirudia, ziko hapa, lakini kikumbuka prime vendor, jamani, yuko wapi Dennis? Nimefurahi naye amekuwa awarded. Yani haikuwa kazi nyepesi, lakini ilikuwa rahisi kwa sababu kuna contribution ya kila mmoja. Na niombe tu tuendelee kushirikiana katika haya mafanikio. Wakati tunazungumzia masuala ya technology kwenye afya, mnajua kabisa hata muuguzi, hata medical attendant alikuwa yani expertise, anakorokocha mabipi machine nini, lakini tumeweza mpaka kuwa na mfumo. Nimefurahi sana hapa mnamtaja Mfanga ambaye yeye ndio alikuwa anaongoza katika timu cha technology, alifanya kazi kubwa. Kwa hiyo mimi niseme tu kwa niaba ya wote ambao wamefanya haya mambo yakafanikiwa, tuliona hapa kina Dr. Mtasiwa. Kwa hiyo kila mmoja ana mchango wake katika mafanikio. Mimi niseme nawashukuru kwanza kwa kurecognize. Nimshukuru sana Fiona kwa kuhakikisha kwamba mimi nafika, na nimefika, nimejionea kwamba mimi sasa ni sehemu ya mafanikio ya hii project. Tulianza Dodoma Regional Referral Hospital, lakini tunaona sasa imeenea nchi nzima katika mikoa 26. Mimi Zainabu ni yule stakani badilike, na natamani hichi kilichofika hapa kisiishie hapa. Tumezungumzia CHF iliyoboreshwa, sasa hivi tunaenda katika bima kwa wote. Ni kitu tunaweza kukiona kidogo, lakini wakati huo kilikuwa ni kikubwa sana. Watu walikuwa wanahangaika. Community Health Fund ilikuwepo, lakini kwa niishi katika community huko kwenye zahanati, sio zahanati, lakini waliwezesha itoke kwenye zahanati mpaka ifika katika hospitali za rufaa za mikoa. It is a task. Kwa hiyo Manfred na timu yako, balozi na nchi nzima ya Swiss, kwa kuwekeza kwetu katika afya za Watanzania, mifumo mizuri ya serikali, demokrasia nzuri, polisi nzuri, ndio zimefanya mkawepo hapa. Kwa hiyo hii mwisho wa miaka 10 ianze miaka 10 mingine kuanzia leo. Nimesikia project is ended 30th of October. Basi tunatamani tuanze project mingine ya miaka 10 kutoka 2023 mpaka 2033. I'm sure Manfred and the entire team will be alive and well. Asanteni sana, Mungu atubariki. Mimi nawashukuru kwa niaba ya watu wote, kina Dr. Ibenzi, kina nani. Yaani tulikuwa tunafanya hata tujielewi. Lakini kwa sababu kulikuwa na watu wanatamani tufike kule, tumeweza kufika. Kwa mimi nashukuru zaidi ya sana. Mungu awabariki katika kazi zenu, tuendelee, maana udugu upo, balozi upo, nchi upo. Mheshimiwa Rais anazidi kupaza huko demokrasia, kutafuta wawekezaji, wadau, na nyinyi ni wadau muhimu sana katika nchi yetu. Na mimi bado ni mdau muhimu. Nipo still katika system, bado ni mtumishi wa umma, lakini katika maeneo mengine. Asante sana MC Selemani, uko wapi? Mbona kanikimbia? Karibu na kurudishia kwa niaba ya wote wamefanikisha mradi huu. Mimi naomba niseme asanteni sana kikubwa kwa recognition. Asante sana.
Mimi nakukumbuka kwa mengi pia. Nilikuja nikapata jasho la meno pale ofisini kwako wakati uko TAMISEMI. She's very practical, usually. Some people say that the strength of the government is bureaucracy. And the definition of bureaucracy sometimes in ile tunaita mchakato. Nenda rudi, but she was bureaucratic very practically with the real definition. Nitakusimulia baadaye mama, wakati wa lunch nitakaa na wewe ulivyonitoa jasho la meno. All right. The second speaker in this session is Professor Meshak. You have heard his name many times. So we welcome you, sir.
Asante sana wote mlioko hapa. Mimi sina mengi ya kusema, ila ningependa kuongeza yafuatayo. Kwanza, natoa shukrani zangu za dhati kwa SDC kwa sababu huu mradi haukuanza hapa. Huu mradi, kabla hujawa mradi, nilikuwa mimi na project yangu personal, nikawa naifanyia kazi kule Dar es Salaam katika tarafa moja. Nilipokuwa nafanya huko, SDC wakatokea wakasema tufanye pamoja, nikakubali na tukafanya nao. Na natoa shukrani za pili kwa U-class, chuo ambacho nilikuwa nafanya kazi. Wakaniruhusu nifundishe asubuhi, saa 6 niende nikasimamia mradi, saa 8 nirudi. Tulifanya hivyo mpaka mimi nilipo staff nikaja Dodoma. Kuja Dodoma, hawa watu wa SDC wakaendelea na huu mradi, wakakubaliana na serikali. Mimi sina habari wakati huo, maki nilipoondoka niliacha. Nikawa hapa Dodoma nikiwa nimefungua chuo cha St. John's. Kwa hiyo chuo kikuu cha St. John's kilipokifungulia, wakati niko katikati ya kukishughulikia hiki chuo, nikaona siku hiyo ujumbe umekuja wa SDC na ujumbe wa wa serikali. Naambiwa uondoke hapa urudi ukafanye kazi hii ya serikali. Ulianzisha mwenyewe, sasa inatakiwa iende nchi nzima, kwa hiyo uende. Kwa hiyo St. John wakakubali na kanisa likakubali. Mimi ni mtoto niliyekulia kanisani, kwa hiyo ilikuwa lazima kanisa liseme ndio. Kwa hiyo walipokubali, nashukuru, nikaja tukaanza huu mradi, na ndio wakatuletea wataalamu wao kutoka Swiss TPH. Lakini concept yenyewe ilikuwa, dhana ilikuwa tayari tulishaitengeneza na tulikuwa tumeshafanyia kazi kama miaka 3. Kwa hiyo walipokuja watu wa Swiss TPH, tukafanya nao, tukaelewana, tukaendelea, tukafika tulipofika. Kwa hiyo nawashukuru Swiss TPH kwa kuja pale na kufanya kazi na sisi kwa kujua kwamba tunaelewa yale na kwamba tulifanya kazi nao. Haya ndio maeneo makubwa nilitaka kusema, kwamba miradi mingi inaanza kwa watu wanaofanya kazi na kujua kile kilichoko. Na kwa sababu hao walijua na wakatutumia, na mimi nikafanya kazi kwa miaka kama 8 hivi au 9 nikastaafu. Kwa hiyo kwa kifupi, cha msingi ni kwamba kuna mambo mengi mazuri yanayofanywa na wataalamu wanaofanya utafiti ambayo ni ya muhimu kuyaelewa undani wake, kwa sababu kama SDC wasingeelewa hilo, hawangeona haja ya kunisaidia kule Dar es Salaam kunisupport. Kama chuo cha U-class kisingeelewa au chuo cha St. John kisingeelewa, isingeruhusiwa kufanya hizi. Kwa hiyo kwa yote haya, nyinyi wenzangu mlioko kazini, nyinyi wenzangu ambao ni mabosi, ukiona mtu anafanya kitu, jaribu kulielewa analofanya, na unapolijaelewa jaribu kulitumia na kuona linaweza kusaidia vipi. Sasa hivi mradi huu umeendeshwa sana na hawa watu ambao walikuwa committed, ambao ndio wale wafanyikazi wa HPSS. Nasema asanteni sana nyinyi wafanyikazi wa HPSS, kwa sababu mmefanya kazi kubwa sana. Mimi ninafurahi sana, kila siku ninapokaa huwa nafikiria miradi hii mikubwa miwili, HPSS na St. John, kwamba inakwenda vizuri. Sasa HPSS mnanipa raha kwamba leo tunafunga kitu kilichofanikiwa, sio kilichoshindwa. Asanteni sana sana sana. Asante sana Alikebi kwa kukabidhi na ukaendelea. Asante sana Manfred kwa kufanya kazi na Alikebi, badala ya kupambana mkaungana mkafanya kazi pamoja. Asanteni sana kwa wale wataalamu wote wa HPSS. Asanteni.
Asante. All right. Ilikuwa tusikie neno kidogo kwa Dr. Deo Mtasiwa naye na nadhani mmesikia jina lake likitajwa mara kadhaa, lakini kwa bahati mbaya hakuweza kufika. Kwa hiyo tunawashukuru sana wazee wetu ambao mmetuongoza, mmetuonyesha njia na mpaka tumetengeneza hiki kitu kikafikia hapa kilipo. Alikebi anasifiwa sana leo, lakini kakuta mtumbu ushachongwa huyo. Waliochagua aina ya gogo gani ambalo halinyonyi maji na nini walikuwa ndio nyinyi, mkatuonyesha namna ya kuchonga. Tungeweza kuchonga mbele ikawa wanaita square, lakini mkatuambia mtumbu kwenye maji lazima mbele uchongoe, si ndio eh? Yeah, kwa hiyo tunashukuru sana. So we move to another speaker, and this time we are going to have a short presentation, and this presentation needs to inform us about the technicality that the project used to register the achievement that we are talking about today. We have heard about the achievement in the morning, but how these achievements were made a reality. So we are inviting Mr. Manfred, the project director, to make a short presentation to tell us about the concept, approaches used, which registered the results that we are talking about today as achievement. Karibu sana.
Yes, thank you very much. I will keep it very short, I hope. Let's try out whether this works. Yes, perfect. So thank you very much. And many things already have been mentioned, so I think I can also keep it short. HPSS is a cooperation project between the Swiss and the Tanzanian government, implemented by this Swiss TPH, the Swiss Tropical Public Health Institute, and has been implemented together with MOH, PURALC, and the regional and district authorities. We had 3 phases starting from 2011. First phase was concentrated on Dodoma region, so here's our home ground, and as Dr. Chaula has mentioned, we started here and the ideas were developed. And then in the second phase, we expanded the support with the government to Morogoro and Shinyanga. And since 2019, there's a national level support for all districts in mainland Tanzania. So we have a systems approach for improving health. It's a bit difficult, I think, to see here, but you can see it includes governance, financing, the human resource development, and all the medicine and health technology development. In the brochure, which you find on your table, this graph will be there in more detail. You can then look for a brief summary of what we did and for the approach there. So, as has been mentioned in the morning, our philosophy was not only to concentrate on one single issue, like medicine or human resources or whatever, but look at it as in a bit holistic and integrated way. No? Why doesn't it move now? So the working areas, as we mentioned, you saw it in the film already: health promotion, health financing, medicine, supply and management, health technology management. All of these components were also accompanied by digital health work and also accompanied by operational research. The principles were consolidation and coordination of key innovations at national level, capacity building for sustainability, and a logical project exit, meaning leaving no loose ends behind, but integrating everything in the government structures so that once the project is closed, nothing collapses. So I hope we achieve that. In detail, they innovate and pilot strategies, mechanisms, and approaches with our partners from government, but also from the civil society and business sector. We had partners like health technology. We developed very much together with private partners and IT, of course. Then joint annual work plan between MOH, PIORALC, NHIF, and HPSS. At the end, in the last 4 years, we even had an integrated work plan which was signed by Ministry of Health and PIORALC and our side, and approved from all sides. Joint supportive supervision of all interventions. The role of HPSS was technical advisory contributions, mentorship, and coaching for knowledge transfer. And in the technical contributions, what we experienced is that the ideal thing is to combine international and national knowledge. That proved to be very effective. We have people here in Tanzania who have great skills and great knowledge of doing things, but pairing them with international experts. Two of them we have here, Karin and Jirgi, on drug management and IT management and health insurance. Pairing them with international experts proved to be very valuable, because then you get additional ideas, additional backstopping from the methodology and everything, and don't lose the local knowledge. So that was a very important point. Joint research. Here we had an advisory committee for research. We conducted, I'm not exactly sure where we are now, but it must be about 20 studies which are either already published or in the process of publication in a peer-reviewed journal, and then of course some newspaper articles and so, which from time to time showcased a bit the work of the project. And support policy and strategies formulation, that was a strong element of the project as well, not only the technical side, but we were quite actively supporting the ministry and TAMISEMI in a number of guidelines, standard operating procedures, and so on all these topics. So with health promotion, for example, there were a number of national level guidelines coming out, although the component was only implemented in Dodoma. So aligning interventions and activities to government priorities. Here we have the health sector strategic plans, number 3, 4, and if it appears, also number 5. Yes. So in these documents, I come to it on the discussion of CHF. We took up the government objectives. Now in phase 3, I just briefly show you that it was a complex project set up, because we had the technical support team with a technical support facility integrated with PIORALC and Ministry of Health, with a health resource center, health system strengthening resource center coordinating the work. So that was the technical components, but then we had digitalization support across all components and evidence generation and capitalization, meaning the research and so on, also across the components. So results, I'm coming to an end already. HPSS supported the reform of the community health funds. We'll talk at it in the next session. The model social health insurance scheme being implemented in the country. It took quite some time to build up the basics and the foundations which are there now. I think that's a good starting point then for the future. The scheme is supported secondly by the IMIS, Insurance Management Information System, which was developed in Tanzania. Our colleague Jirgi Nemetz is here, who is the father of the IMIS system, conceptualized it, and together with a Tanzanian company, Exact, did the first developments here. In the meanwhile, I counted it, it's 12 countries which are implementing the IMIS initiative. Cameroon, Chad, Congo, both Congos have something, Mauritania, Nepal, Niger, Tanzania, mainland, and there's an element also in Zanzibar, Gambia, Ethiopia, Comoros, and Myanmar, and there might be more coming because it's now embedded in an open source community. That means this software, as a health insurance software, is freely available for everyone, governments or whoever wants, and they can download it from the internet without fees. And all countries which do that participate also in the development of new features. ICHF has registered 4.5 million Tanzanians, but that is the cumulative figures. Many have dropped out, but I come to that later. So we're still struggling, or the government is still struggling to see how best to get that scheme to the population. And the results and experiences are being used by the government to inform the process of developing the National Social Health Insurance Fund, or UHI, a Universal Health Insurance framework. So that is an ongoing political discussion, but this is an element of it. Number two, the health commodities supply chain. Here the prime vendor system was developed, addressing health commodity shortages, basically providing a channel that when MSD can't fulfill 100% of the requirements, the rest, the gap, is taken up by a private pre-qualified vendor. Again, an IT system was developed to help coordinating that system with the MSD reporting of stockouts and so on, and the ordering. Then this component also contributed to the reviews and development of national standard treatment guidelines and the essential medicine list. We developed the stratified standard treatment guidelines for primary healthcare, taking the big book from the government and breaking it down, simplifying it for the primary level, making it applicable or handy there. We designed and tested medicine and financial audit mechanisms, because increasing supply is one thing, but at the same time you have to look that medicines don't disappear from health facilities. We contributed to the National Action Plan of antimicrobial resistance. And finally, we established an accredited course at St. John's University for dispensers. And that is a cadre which is specifically for the health centers in the rural areas and so on, where they don't have a pharmaceutical qualified staff apart from those. Health technology, greater understanding of health technology management at all levels of decision making. I think we have our colleague here, Suniva. So I think we can be proud that we have been a certain catalyst of supporting the government in taking the repair and maintenance services to a higher priority on their schedule, and which led to cost savings, because you don't have to replace equipment with new equipment if you repair it. Then we established a National Calibration and Training Center here in Dodoma. Then 4 regional and 5 district maintenance workshops were established and equipped with tools. We supported the development of the IT system for managing equipment repairs and maintenance, MIMIS. So you can centrally see now here at the government which health facility has which equipment in place and in which state of functioning or repair or disrepair it is, and which kind of spare parts are needed. So this synchronizing of spare parts and equipment is also part of the cost savings, that you don't have 20 different machines for the same purpose, and you have the right parts at the right point. Then we established a national level competency-based training on biomedical engineering at Mvumi Institute of Health Sciences. Such a course existed some 20 years ago, whatever, and we kind of helped Mvumi to revive it and to get it accredited and equip it and have the trainers there and so on. The joint activities imparted a culture of maintenance, we can say. So finally, health promotion. We tried to support the government in reforming health promotion approaches. There have been times in Tanzania where this was stronger. I know that, but it has gone a bit lost with health education approaches, just telling people what they need to do for improving their health. So health promotion would try to activate their resources and ask them to develop their own plans for improving health and coordinating then those activities with government support and budgets. So I think that was also quite successful. We gave inputs in a number of guidelines, national policy guidelines, school health service policy guidelines, sanitation guidelines, and NCD action plan. We piloted and supported national implementation of health promotion and supportive supervision. And there's a course now at UDOM, University of Dodoma, the first course on health promotion, where professionals from government or NGOs can be trained in these health promotion approaches, working with the communities. So that was also an important breakthrough. And we contributed to customizing AFIA supportive supervision system, again an IT system. Okay, I would just like to acknowledge our partners. I don't go through all of them again, but also briefly mentioning that we have always worked in joint activities and working groups, in Ministry of Health technical working groups we contributed, ICHF implementers group with other partners. So that was always a joint journey. And I would like to extend a word of thanks to all partners from government and non-governmental organizations who accompanied us and worked with us during this 12-year journey. Thank you very much. Asante.
So thank you very much, Manfred, for taking us through how you did it and highlighting the key research areas which constituted the achievement that we have been hearing from the morning, and particularly through the video clip. I think it is a big job. One of the things that I would like you to note down for the group that is going to be in the panel discussion for what you call health technology management. I think there's also an importance of including behavioral change among our people at workplaces. We've always included health promotion, highlighting behavioral change for the community, but what we saw through this project were small damages like a broken wheel in a hospital bed, cause for throwing away this bed, which would have been easily fixed, is a behavioral matter, and it needed to be addressed. There was a time I was involved in a study to evaluate referral hospitals in Tanzania, Bugando, KSMC, and Mbeya referral hospitals. When we went to Bugando Hospital, there were more than 100 beds which were dumped because they were broken. And when we conducted the assessment of the damage, they could have been easily fixed. And this is actually what you are trying to fix in this project. But creating a batch of people who can fix is one thing, but developing the behavior of seeing that this can be amended is another thing. So when we, in the future, when we do the health promotion, is particular behavioral change, we should not only target the community and the behavioral change in terms of how we use health services, we should also change ourselves. This is my contribution, because I know I may not be an active participant in the panel discussion. Our second speaker, fourth speaker in this session will be Dr. Kengia. Dr. Kengia is going to share with us the perspective from PORAG on how they perceived this project and how, as the key implementer of all the health-related interventions, have taken on board the issues. Karibu.
Asante sana. Thank you very much. So I'll be doing this presentation on behalf of Dr. Ntuli Kapologwe, the director. So the slides, please. Yeah. So the presentation is all about building from the previous presentations, but just giving the eye view of PORAG when it comes into the outcome of the project. And ideally, us as a PORAG, we've been working together with the HPSS project as implementers of the projects in a number of ways, and in particular through our mandate as PORAG in the coordination of the implementation of the project in the local government authorities. So of course we are working together with the Ministry of Health in terms of the policy and guidelines, but really a role was to ensure that the implementation takes place. And the two important areas there, you can see from the two bullets at the end. One is we are able to establish a kind of a virtual website, hssrc.go.tz, as a kind of a platform where we can share some of the health system related innovations. And the other important thing is what was also summarized by Manfred. We're talking about here all the issues in the project components, the implementations, the area of ICHF elaboration, Jazia prime vendor, the Mshitiri, health technology management, and health promotion. So I'll go one by one a bit. Next slide. Yeah. So when it comes to the capacity developments from the project sites, as PORAG, we see that the project really have supported some of our staff. Countrywide, we are talking about 150,000 staff from the regional secretariat and local government authorities in all the 26 regions have received some trainings and the project component areas, some in the CHF elaboration, some in the Jazia primary vendor system, health promotion, health technology management. Of course, I already said about the establishment of the virtual platform, and also, of course, another very important area to PORAG was also to establish the CHF elaboration units that is now well equipped with some equipment and the capacity built into the staff, the training component. And the other thing that is important here is also we are on the way of strengthening the Jazia implementation team in our department with all the equipment, and of course the staff there were also trained. And in general, there was a lot of capacity buildings from the area of health promotion and health technology management. Next slide. So when it comes to CHF elaboration as one of the components of the project, in principle from our eye view as PORAG, the project has assisted when it comes into the establishment of the system. Talking about the coordination mechanism of the ICHF from the national, regional to the district levels. And one of the important area there you can see in the first bullet, the ICHF itself is all the operational expenses are self-financed within the system. And when it comes to enrollment of members, you can see that to date, cumulative, we are talking about 4.5 million people that have been enrolled. That is the individual members. But of course, you can see on the diagram there that there was kind of some variation when it comes into the enrollment from one year to another. But for the year 2020-2021, you can see there was a kind of a peak there with around 45,000 when it comes into the household enrollment. But of course, for the recent years, you can see that it's a bit going declining. Of course, some of the reason is, recently we had some discussion when it comes to universal health insurance. So all the kind of the health promotion activities were limited. So then you see the ICHF enrollment is going kind of declining. But what is important here is when it comes into the premiums that has been collected. So to date, we've registered around 33.2 billions. That is the amount of resources that have been collected in terms of the premium. But if you see there on the diagrams, the annual premiums, the year that we had a lot of resources was 2021 up to 2022. Kind of the project was on its peak, but there was a kind of declining. Of course, you remember about the issue like the COVID-19 and the likes and the recent discussions. But what is important here is a take-home message. ICHF Iloboreshwa managed to have the premium collection of up to 33.2 billions. Maybe the question is, where did this money went? Next slide. So through all these years, the resources that were collected from CHF Iloberesha actually went to finance the access to care, improvement in the access for care. So we are talking about around 80% of CHF members that attended at the primary care facilities were able to receive the care through the ICHF contributions. And of course, down there you can see that majority of the people went in the health centers and dispensaries. And of course, we have a number of people also that are going to the hospitals. Here we are talking about the district hospitals and regional referral hospitals. But mainly here you see a lot of people that are accessing the care through ICHF Iloboreshwa in the health centers and dispensary. What does this mean? This means that with the ICHF Iloboreshwa, you are able to really have more people have the access, because more people will go to the dispensary and health centers as the first resort of cares in the primary care. So with the ICHF Iloboreshwa, those people were able also to have some access for care. Another important takeaway here is when we talk about CHF Iloboreshwa here, we have a number of people that are also hospitalized. Cumulative, we're talking about 1.5 millions, but out of 1.5 millions, 45.4% of those people were able to attend in the health centers and get hospitalized. And you know the distribution of health centers countrywide is more, then that means also you are able also to reduce kind of inequity in access to care, because of majority now are able to get access to the facilities, and of course with those succumbing to catastrophic health expenditure because they have the ICHF card. Next slide. Yeah, so this one is the total contribution premium collections from the level of dispensary, health centers and hospitals, from where we started the ICHF to date. So you can see from that table, majority of the resources in terms of reimbursement went to the dispensaries. That amounted to date around 10.6 billions. But there are some of the resources that went to the health centers, that is 5.5 billions, and others went to the hospitals. Here is around 80.5 billions. That is district hospitals and regional referral hospitals. And the other area that work together with the HPSS is the area of strengthening health commodities supply and management, where, of course, it was already talked in the morning, the establishment of the prime vendor systems from the pilot phase to the national rollout. So today we are talking about a countrywide implementation of the Jazia prime vendor system. And the other thing that is, as the project ends, being developed, we also developed the sustainability plan, and it was already approved, so that the project, as it ends, the issue of PVC continues. The other thing, there's a number of studies that were also conducted as evidence. And one of the very important study here is a study that was the implementation fidelity for the PVC, prime vendor systems. That actually helped us to move from the previous 1 prime vendors per regions to currently now we are talking about 4 vendors per regions. That was evidence that came from the studies, helped us to inform how best you can further improve the PVC system. Of course, the last period is not seen, but currently there's also ongoing process of developing the IT system for the prime vendor system. So this is Jazia. What Jazia really helped us is it improves some transparency and accountability for public funds and reduces the procurement processing time. That is some of the advantage of PVC system. But of course, what is critical here is when we are discussing about how can we complement the MSD. So some of the findings, for example, from a CAG report that has showed that the MSD can support availability of medicine up to the 60%. Then the 40% gaps can be really filled by Jazia. And the other thing that is important here is through the prime vendor system, we're able also to ensure the value for money. Because you enter some of the contracts, then in terms of going like a different vendor without a contract, then you can be able also to minimize some of the cost when it comes into the medicine procurement, health community procurement at large. The other area that we work together with the HPSS is the HPSS technology management. And here, what we have registered is one of the outcome of the project is what we call the capacity building. Yeah, in terms of orientations and the trainings for the use of medical equipment and infrastructure management information system. Yeah, it was the training was conducted to regional secretaries from 26 regions and 184 local government authorities. So from them, we are sure that they were able also to replicate to their area of jurisdiction. And the other thing that there is important, through the HPSS, we are able also to conduct the inventory exercise to all the 26 regions to know and register the medical equipment countrywide in our facilities. But of course, through the same period of the project, the government had employed some of the biomedical technicians and engineers, 102 in the year 2021-2022, and 79 biomedical technicians and engineers in the year 2022-2023. But of course, through as something that is coming also as a force from the project or advocacy aspect, we are also advocating for the planned preventive maintenance and repair budget to be accommodated in our plans, CCHP and facility plans. And last take-home message there, this area still needs strong support to be fully internalized at the lower levels. So we still need some full support to ensure that we internalize this area of health technology management in our lower level facilities. Sorry. So the last area is the health promotions. For the area of health promotion, we've registered an important area in strengthening the issue of the performance of health promotion systems in our region and the councils through, number one, the issue of supervisions. So through the project, we are able also to come up with the supervisions tools that also we're also able to kind of orienting our staff at the level of the region and councils, talking about the national, regional, and council health promotion coordinators, so that they are able now to conduct the integrated health promotions initiative in our areas. And of course, through this project, also to advocate for the inclusion of health promotions budget within our plans. Having said that, asanteni sana kwa kunisikiliza.
This highlighted from the perspective of the government, the peerage end. Tunasema kwa Kiswahili wote tunaweza kutazama lakini tusione sawa, si ndio? We can all look at something but we see differently. So we have been hearing this achievement and successes from different perspectives. The way the embassy, as the speech by the Honorable Ambassador documented the achievement is a bit different from the way Manfred, as a project manager, illustrated, and we can see that it is a bit different, although we are talking of the same thing, but from a different perspective. In the same line, then, we invite the Office of Director of Policy and Planning, which will be represented by my brother, Claudi Kumalija, to hear what they see the project from their perspective as the policy guarantees as far as health policy in Tanzania is concerned. Karibu sana kaka Claudi.
Asante sana, na mimi sina presentation ila naomba niseme maneno machache. Katika kipindi kama hiki ni muhimu ku appreciate wenzetu HPSS wamefanya kazi kubwa, na katika kipindi hiki chote tumekuwa tukishirikiana nao na wameweza kutoa support kubwa sana serikalini. Kwa hiyo naomba niseme machache tu kama shukurani kwa niaba ya mkurugenzi wa sera na mipango Wizara ya Afya. Niseme mambo machache kama maneno ya kuwashukuru, lakini pia kipindi cha kuachana huwa ni kipindi kigumu. Wanaondoka. Hao watu wote tuliopo hapa tulikuwa tumesocialize, tumekuwa kama jamii moja. Sasa mnaondoka. Mnatuacha, tunafanyaje? Lakini tuwashue kwamba mambo mliyofanya tutaendeleza kwa sababu ni mambo mazuri. Kwanza kuna mambo makuu mawili ambayo nataka niyazungumzia hapa. Eneo la kwanza, mmetusaidia katika eneo la policy formulation. Na eneo la pili, mmetusaidia katika kusimamia projects mbalimbali. Na katika eneo la policy formulation, naomba nishukuru kwa kutaja maeneo ambayo kwa kweli tutawakumbuka kwa sababu mmeweka icon yenu katika serikali ya Tanzania, Wizara ya Afya. Kwanza niwashukuru kwa kutengeneza primary vendor implementation manual. Mmetusaidia kuitengeneza, lakini pia mkatutengenezea na vendor guide. Sio hivyo tu, mmetutengenezea monitoring and evaluation guide, lakini pia mkatutengenezea primary vendor management information system. Hizi dokumenti zote tumeweza kuzitengeneza, ni policy documents, tumezitengeneza kwa kupitia ushirika wenu mzuri. Mmeweza kutusaidia kupata primary vendor policy guideline. Hii document is still in a draft form at the hospitals. Tunawapongeza sana kwa msaada wenu ambao sasa umeziwezesha hizi levels mbalimbali kuweza kuoperate smoothly. Lakini sio hivyo tu, mmeweza kutusaidia kutengeneza CHIF iliyoboreshwa operation manual. Hii document nayo bado ni draft, ni document ya kisera, bado ni draft, lakini tunawahakikishieni kwamba pamoja na kuwa mnaondoka, sisi wizara kwa kushirikiana na wenzetu TAMISEMI tutahakikisha document hii imekamilika na iko operation. Mmeweza kututengenezea standard operational procedures, CHF standard operational procedures. Document hii tunaitumia, tunawashukuru sana. Mmeweza kututengenezea national policy guideline for healthcare technical services. Iko katika draft form na very soon tutaikamilisha ili iweze kuwa approved na kuanza kutumika ndani ya sekta. Mmeweza pia kututengenezea implementation manual for healthcare treatment services. Hii nayo bado iko katika draft, mnaiacha ikiwa katika draft, lakini tunaomba tuwashue kwamba tutaifanyia kazi kuhakikisha kwamba tumeikamilisha. Kuna policy document nyingi mmetusaidia hata kuja kutoa technical inputs zenu ambazo tumekuwa tukifanya kazi pamoja na nyinyi, lakini pia kwa upande mwingine mmekuwa kutusaidia katika implementation ya projects. Ngoja nitaje baadhi ya project chache ambazo tumeshirikiana na nyinyi. Insurance Management Information System, hii tumetengeneza wote kwa pamoja na ikawa implemented. Medical Equipment and Infrastructure Management Information System, hii nayo mmetusapoti, tunawashukuru sana kwa support yenu, kwa uwepo wenu, mmeweza kutusaidia kukamilisha hii document. Kuna National Collaboration and Training Center, pia mliweza kusaidia mafunzo katika workshop iliyofanyika Mirembe Hospital. Lakini pia kuna Regional Maintenance Workshop mmeweza kuisupport kufanya katika hospitali ya Iringa RRH. Tuliweza kufanya kazi na nyinyi katika Regional Maintenance Workshop iliyofanyika Mount Meru Hospital Arusha. Tuliweza kufanya kazi na nyinyi pia katika Maintenance Workshop iliyofanyika Shinyanga Municipal District Hospital. Lakini pia tuliweza kushirikiana na nyinyi kufanya Biomedical Engineering Training Facility at Muvumi Institute of Health Sciences. Lakini pia tuliweza kushirikiana na nyinyi kufanya Health Promotion Training Center at the University of Dodoma. Lakini pia tuliweza kufanya kazi na nyinyi katika Medicine Dispenser course katika St. John's University of Tanzania. Kwa kusema hayo machache, naomba niseme tu kwa niaba ya DPP kwamba tunashukuru sana kwa support yenu. Miaka 12 ni miaka mingi. Mmekuwa sehemu ya Watanzania, na tunaomba sana in future tuendelee kusaidiana, kushirikiana katika kusaidia watu wetu upande wa afya, na pia nawatakia kila laheri katika miaka mingine inayofuata. Karibuni sana. Sisi Wizara ya Afya tunawakaribisha tena kwa namna nyingine ambayo mtakuwa tayari kushirikiana na sisi, kama nilipokuwa nasikiliza hapa. Kuna maeneo mengi, kwa mfano eneo la universal health coverage. Tunahitaji contribution yenu kubwa kuhakikisha kwamba kila Mtanzania anapata bima yake na anakuwa salama kwa ajili ya maisha yake. Mimi naomba niishie hapa, na washukuruni sana, asanteni sana.
We thank every speaker who have taken us through this session, because it enriches our comprehension and understanding, and which will facilitate reflections of the project and its achievement, the processes that have been documented, and how the government is prepared to take them aboard as we go. Sasa nilipokuwa nikitoka kule, somebody alerted me that there's a rat which is going on here, moving from one area to another, so it might be under your table. Can you please stand up and look down if the rat is under your table? You stand up, all of you. There's a rat, big one. Did you see it? If you didn't find it, sit down. Tukae. So according to our schedule today, we are supposed to end the day by conducting 2 panel discussions. We have our lunch waiting for us. So I propose we take 1 panel discussion session, which will take us close or just a few minutes after 3, and then we shall go down, have lunch, and then we come back and conduct the 2nd panel discussion. As I told you in the morning, usually I'm a participatory believer. Is it accepted? Okay, fantastic. Sauti lakini haitoshi. Pale bungeni speaker asingeweza kuhalalisha. Lakini tunakubaliana. So, we will undertake the first panel discussion session, we are asking the organizers, I think there was a plan to remove the tables here. We don't need them anymore. So if we can do that now, while we are introducing the moderators for these two panel discussions. If you think we can still conduct this with the tables remaining here, if we have a change of plan, it's well and good. Just to remind the organizers, they said they would like the tables to be removed during the panel discussion. Are we still holding that? Okay. Yes, Ali. Okay. Henry, tunaondoa meza au tuendelee kwenye panel discussion? Kuokoa muda tuendelee. Okay. Okay. Sawa. So the first panel discussion will be on CHF iliyoboreshwa, improved CHF. This session has been prepared in order to discuss what actually was different from what we knew about CHF. This is the layperson definition of innovation, huh? Doing the same thing but in a different way. So we want to hear, why did it qualify to be called CHF iliyoboreshwa or improved CHF? What we have done, whatever that was done, how successful was it? And has it been rolled out country-wise, or it is just implemented in some areas, etc. So there shall be one keynote speaker who will address these issues in a very concise way, and that will prompt discussion. So this session will be moderated by Dr. Tumaini Kengia. Discussion, then after that, we'll join this session and go. Okay, so a note has been submitted to me, somebody, or if it is a team, they are advising that we do the two panel discussions and finish, and then we have a late lunch, rather than breaking in between. So this is a big yes, eh? All right, clap the tables. You clapped your hands, you didn't clap the tables. Asante sana. I was saying that the first session on CHF iliyoboreshwa will be moderated, ananipumzisha kidogo, will be moderated by Dr. Kengia. Dr. Kengia has been, his name has been up and down today. Nitafunguaje? Nataka nani yako nisome. Wewe kwako ni problem? I mean, oh yeah. My apology. The first session is moderated by Cookie. Where is Cookie? Kaka Cookie, are you around? Sorry, I confused here. So the first session, sorry, it will be moderated by Mr. Cookie Tarimo, who is an economist and who has honed his skills from his work, both in the public and private sector. He has spent 12 years working as an economist in different institutions, including working with the Minister of Health. Mr. Cookie provides knowledge of health financing and costing expertise for development of health financing policy in Tanzania. He is well equipped with different knowledge on working with different stakeholders, including development partners and government, both in the mainland and Zanzibar. Cook is also well versed in health-related strategies and health financing on the agenda of domestic resource mobilization, including conducting resource tracking studies, HIV/AIDS, health financing reforms, costing strategies, etc. He has also developed and produced policy briefs from his work, and he continues to do that to date to inform the health sector reforms. Currently, Cookie is working as P4H country focal person in Tanzania. Karibu Bwana Cookie. and we can applaud him as he walks to the front. Karibu sana.
Habari za mchana. Good afternoon all. I was informed that we are going to mix, so we'll use both language, English and Swahili, on our panel. And thank you very much, the organizer, for this opportunity of actually appointing me to moderate this session. And I think we are running out of time. I would like to call the panelists, and I'll a little bit give the brief bio of those panelists. So first I would like to call Mr. Sylvia Maganza, who is the ICHF coordinator at President Office, Regional Administrative and Local Government Authority. He has been working in the health sector for quite some times, and he is very well knowledgeable, and currently he's coordinating all the CHF activities at PORAJ. Karibu Mr. Mgonza, please. Tunaweza tukampigia makofi kidogo. I would also like to call Mr. Yasin Kisawaki, who is the regional ICHF coordinator for Dar es Salaam. Mr. Yasin, by professional, has a lot of experience in health insurance and has worked also in social protection for quite some times. And currently he's acting as ICHF coordinator at Dar es Salaam region. And we know Dar es Salaam is one of the urban area, a very complicated region with different premium from other regions. So we'll love to hear his experience on that. Karibu sana, Mr. Yasin. The third person is Dr. Ali Musa, who is the medical in charge of Mbagala District Hospital. He has been working in the health sector for quite some time, and has been like ameona mambo mengi ya ICHF yanavyokuwa implemented na ana experience ya hali ya juu sana. Karibu doctor. The first panelist which we have here is ACP, Dr. Oswadi Kambelenja. This man is from Manyara. He's working with Babati Police Dispensary, which is a dispensary owned by the police. He is currently an assistant medical officer and facility in charge. He has experience of more than 33 years working in the health sector. In ICHF, he worked also with different reforms of ICHF from the original CHF, ambayo ilikuwa pull at district level, and then he worked with also Banyara, kulikuwa kuna implementation ya Farm Access Project, and now he's working with the improved CHF, ambayo ili consolidate all the experience from different implementer walikuwa wanafanya CHF. Karibu sana. And I would like also to call Dr. Ernest Ibenzi, who is the regional medical in charge for Dodoma. He's very experienced. He has many years in health sector. Karibu sana daktari. Unfortunately, we were supposed to have our colleagues from Ministry of Health, but as you heard from Honorable Minister, one of the agenda currently, and it was in manifesto of CCM, is to ensure that the UHI bill is approved, and currently wako kwenye maandalizi hayo, wameshindwa kufika wataalamu ambao walikuwa wanafanya kazi kwenye maeneo ya CHF. Kwa hiyo kwenye hii panel discussion yetu tutawamisi watunga sera, lakini tutakuwa na hawa implementers pamoja na PORAJ ambaye naye yuko kwenye policy level, lakini hao tumeshindwa kuwapata. And I would also like to call Hali Kebi, the project manager for HPSS project. Nadhani tumekamilika jamani. Tuwapigie makofi, hawa ndio panelists wetu. Maybe starting with, we know for sure that ICHF undergo a lot of reform since tokea kipindi kile ilipoanzishwa miaka ile ya nyuma, na mabadiliko haya yame improve utekelezaji wake katika ngazi mbalimbali. Tunajua tulianza CHF, tukaja tukaformulate task force, tukaja na improved CHF. Mr. Maganza, please can you share with us your experience on the implementation of ICHF kuanzia in different reform, na je, unaonaje hii improved CHF, I mean the implementation of CHF ina mchango wake katika kufikisha Tanzania kwenye malengo ya bima ya afya kwa wote? Karibu Mr. Maganza. Samanini jamani, nimearifiwa kuna kitu nimekivuka. Tulitakiwa kabla hatujaingia kwenye kuwauliza maswali panelist, tupate keynote address kutoka kwa Mr. Manfred. Mr. Manfred, please, karibu. You're welcome.
So there should be a brief presentation. Sorry if you hear me again. On the CHF. I don't know from our IT people. Can you load it? Yes. Okay. So just to walk you through, I tried to make it short, also not to have too many repetitions. The questions was posed by our facilitator, what is different to the old CHF? Why is it Ilio Boreshwa? Does it deserve to be called improved, and in how far? So I would just like to point out some points we made without going now too much into things which we already know. So the reform of the CHF came as a response to the request of the government to support them in the future health insurance structure. That is all under the umbrella of reaching universal health coverage, where health insurance plays a major role and should enable access to health services and protect them against catastrophic costs. I mean, that's the whole rationale, that you protect people against high cost. And this aligns with the central pledge of the 2030 UN agenda, with the Sustainable Development Goals to leave no one behind, where both the governments of Switzerland and Tanzania are following this. The project aligned with the 3 health sector strategic plans. Number 3, improved equitable access to health services. The plan number 4, enrollment in the health insurance schemes. And number 5, implementation of a health financing strategy that maximizes equitable access to quality health services and provides financial protection against ill health. So these are the key words which are all where we align our work with the government policies. Now, what was the characteristics of the old CHF, the CHF which is still in the bill, the CHF bill? It was a very simple scheme where the population was asked to pay or to prepay treatment at one health facility, a primary level health facility near their village or near their place of living. So it had very limited access, as it covered mainly primary care. Some districts on their own, as I understand, also introduced district hospital services, but that was not in the general plan. It was passive enrollment. You had to enroll at health facilities. There was no sales agents or any kind of active agents promoting enrollment. There's no separation of provider and purchaser role. It was all under the DMO, Ministry of Health, both the provision and the CHF. We had family-based ID cards where people had to go to the next town to make a photo and put that on the card. And that transport plus photo often was more costly than the whole health insurance or the whole membership of the CHF. There was no repayment to the health facility, so that was very limited incentive for them to treat members. And maybe the biggest weakness was it was all paper-based. That means at the end of the day, it was not transparent. There were figures like 50% coverage and so on reported to the government. And when we, at that time also, we did studies to see good practice of districts. When we arrived at the districts, the closer you came, the more they disappeared, the coverage. At the end, it was not the true picture. So the reform now to the CHF Ilo-Boreshwa, what did we try to do? We had new organizational structures with SOPs. We tried to introduce active enrollment and renewal at the village level with dedicated people who have this task of enrolling into the health insurance, enrollment officers or agents. Then capacity buildings and trainings at different levels, communication, promotion and marketing, and development of an IT system, IMIS, to bundle everything together. So the use of the information technology included the members of the scheme, the enrollment officers, and the health facilities. The IT system manages enrollment, renewals, inquiries for payment, and facility claim processes for the payment. One advantage compared now to other insurance schemes was that membership cards were issued immediately on the ground. So the enrollment officers were equipped with paper cards, and at the beginning lamination was used, cold lamination, and the names of the household and the person was written there. The card was laminated and handed over immediately. And why? Because it had a QR code on it, and at the health facility level, you scan the QR code and all the information of that family and of that member is then available for the health facility on their screen. You don't need a chip or photo for identification at the card, because the health facility identifies the person then. So that is a big plus, because in other health insurance schemes you have to wait 4 weeks, 6 weeks until you get your membership card back and have all kinds of logistic problems and costs involved. Then secondly, or thirdly, CHF members have access to medical treatments at all levels of public health facilities, from dispensary health center, that's the primary level, district hospital, secondary, and regional hospitals across the country, tertiary level. Why up to regional hospital? Because the only reason why people should buy CHF is that in case of a major illness, an accident or something, they get adequate treatment. And this adequate treatment is only available at the regional level at the moment as we stand here in Tanzania. And if you cut off that regional level and leave people up to the district, why should they buy the cards? Because all these treatments there, they could easily finance out of pocket, maybe, mainly. So the premium is very affordable, 30,000 shillings per family per year, a family of 8 people. It is, from the cost recovery point of view, rather a symbolic contribution. $12 per year doesn't cover really substantial costs. But as it is government hospitals and they're already funded by government budgets in the background, personnel, medicine, equipment, infrastructure is all paid by government budgets. The health insurance in this case acts as a supplementary financing mechanism and it does not replace the budget funds. If that would be the case, of course, you would need more money to pay then the personnel and everything. So at the moment it's quite affordable. Dar es Salaam has a specific regulation with a bit higher premium. And basically it's the CHF is easily accessible all over the country. Is that? Yeah. So the IMIS system, the IT system, as I said, it's able to manage different insurance products. That means you can have a basic insurance, for example, covering the government services up to regional, and you can add additional packages, like for additional services, NGO, faith-based organizations or whatever, or for specific population groups, mother-child health package or whatever. In IMIS, in the system, you can manage different programs, products in parallel. You are also able to manage different options of reimbursement, and that was the whole philosophy of the system. As I mentioned before, Jiří is the father of that system. Together with our IT staff, we developed a system which is multifunctional. So if the government decides to introduce user fees, not user fees, sorry, fee for service payment, then IMIS can manage it. If you decide to use a capitation, again, you can switch it to that mechanism. Then there are different levels of control. At the beginning it was a district scheme, now it's regional or it can be national. It is a regional scheme, but it doesn't influence very much because all regions reimburse payments also in other regions. So the function at the end is already national. And it's an open source software. So I come to the points, if I'm able to. There are a number of electronic functionalities in the system. I don't go through all of them, maybe just a last point. Electronic public monitoring tool for performance monitoring. That is still in the PIORALC and TAMISEMI in development and implementation. The idea there is, and hopefully by end of October, that we have a website where the councillors in the districts can and other people can enter in the name of their location and see how their village or ward or council is doing in terms of membership, whether the village is active or not, you know, for purposes in the ward development committees, follow up. Here you have a tool then to inform the local population or the local councillors how their place is doing. Okay, otherwise it's all integrated in the government systems, MUSE, Gotomis, AfyaCare, GPG with the electronic payment and so on. Oops, what happened? Good. So that's how many people are connected. I just want to come to 2-3 slides at the end and then hand over to the panel. This is a trend of the enrollment. It's the same picture as we just heard from TAMISEMI. In 21 there was the peak of the membership. It was catching up and going higher. And then we had both the COVID, but we had in our observation from our team this discussion on the UHI bill. And accompanying this discussion was this insecurity. Is CHF remaining or not, or will it be abolished? Or it was not really actively promoted by the government, and the population, I think, was a bit confused, and so the numbers went down, unfortunately. It has already been mentioned what the revenues generated are. And maybe just to mention here, 2.6 million treatment visits have been covered by CHF. Then where does the CHF stand today? We have an affordable scheme for the rural population and the informal sector. We have an attractive benefit package up to regional level. We have an easy enrollment mechanism where you enroll at your house, portable ICHF cards all over the mainland country, reliable payment and fast payment. In the meanwhile, I think hiccups have been sorted out mainly, and it's quite fast. A strong IT system and integration. Where the unfinished business, the enrollment mechanism from our side still looks weak and needs more business orientation. The ICHF, due to the discussion, the open issue was always in which form would it participate in the UHI? Is it an own institution or not, and so on. So that structure has to be decided at the end of the day to give it an own management structure and a director or CEO who is responsible for the scheme. Then the CHF is still not known enough with the population. Many people don't know it or confuse it with the old CHF. Then there are certain policy questions regarding benefit package and so on. Here one question is, for example, I mentioned here co-payments, because the government advertises CHF that the whole package is included, you don't pay extra at hospitals. Now we conducted research, we will hear more tomorrow, which found out that at the hospitals are charging extra. And then that is active discouragement of the population to enroll or to re-enroll, because they are frustrated in their expectations. So if there are charges, I think they should be formalized and announced at the hospital wall that these and these services are not included, but not just kind of surprise people we still have to pay. And electronic enrollment is there, but now the non-electronic, non-M-Pesa and so on doesn't work anymore. So that means you can only enroll once you have the Wakala agents in the villages. So let me point out one thing, socioeconomic background. In Tanzania, healthcare costs often exceed 10% of the monthly incomes, both in rural and urban areas. Here the figure, approximately 70% of Tanzanians live in rural areas, and from agriculture the average income is 169, let's say 170,000 per month. Yeah. And 44% of the population earn less than $2.15 per day. And also the business sector is not very strong internationally. It's catching up, but it needs also low costs. Okay, so my last two slides, I think. The CHF, from our thought, the final words of the outgoing project, the CHF should stay affordable for the broad population, even if the costing studies determine that more money is needed to fully recover the costs of a service, but then you need to look for other ways of getting that money into the pool, not only from the peasants and from the citizens. Secondly, additional benefits packages may be explored. Marketing still needs improvement, and the branding and professional management, and maybe the governance structures also, that at the end of the day, the voice of the consumers, of the members, that there's no strong structure yet, that should also be considered. Asanteni sana kwa kunisikiliza.
Asante sana Manfred. Nadhani presentation yake ilikuwa well informed na shughuli walizokuwa wanafanya, na ametoa like perception yake kama HPSS project, nini unachokifikiria. Sasa ametupa overview of the CHF implementation, where it come from, what they are doing now and what are their challenges. Naomba twende moja kwa moja, na dear panelists, naomba to observe time kwa sababu tunaunganisha session mbili, I would love, nilikuwa napenda niwape kila mtu dakika 5 za kuongea, lakini nilikuwa naomba tufanye 2:30. Just be brief na nini the point. Tunaanza na Mr. Maganza. Based on the previous question that I asked you, ni kwamba we know that the health system in Tanzania has undergone various reforms, and which include the development of community health fund. When you look back on these reforms and the situation now, do you see any improvement based on the reforms ambazo zimefanywa kwenye CHF, and do you think its contribution toward the achievement of the goal of the government toward the universal health insurance, yani kufikia bima ya afya kwa wote? Karibu Mr. Maganza.
Okay, thank you Mr. Cookie. Before all, let me join with the other first people who have commented about the 12 years of experience. Even myself, let me congratulate the HPSS for celebrating today the 12 years of experience in implementing various interventions in the health sector in Tanzania, including the ICHF together with the prime vendor and the rest. Going straight to the question, so far, let me thank you, Mr. Manfred, Dr. Manfred. I think he has made a lot to my perspective, because those were the areas at least I could go through to let we all here to be in the same page or on the same page. So with all what has been presented, and having the experience of the community health fund with its evolutions, which we have seen starting from working at a local level, and there now we are at a regional level with the various improvement in benefit package, together with the coverage. I mean the coverage plus the portability status, meaning that the member who is enrolled in Dodoma can go all over the regions and access services. So with all of this which has been mentioned previously, we find that the interest of UHI, or Universal Health Insurance in Tanzania, is to leave no one behind. So the experience of ICHF, we find that it has been working in the informal sector. So with this one, the experience of ICHF working in the informal sector, where the majority of Tanzanians are living, we have seen in the past presentation from Dr. Manfred, where more than 70% of Tanzanians are there, with some of them are employed in the informal sector, but others are not employed, the low income earners. So with the ICHF, with the premium we have even to date, we have seen enrollment increasing and the like. People accessing services. We have seen the presentation Dr. Kengia has shown there. A lot of them, a majority of the ICHF members had been getting services under primary health care at the dispensaries, most of them at the health centers together with the hospitals. So we think if really we want to leave no one behind in the coming UHI, it is important that the ICHF to be included. So we are confident of giving our experience in taking care in these areas. But again, we have seen the issue of infrastructures, the ICT system. But again, we have the human resource in place. But also we have the members. The data shows over 40 million members. I mean 4 million members are in the fund already. So we think this is a strength. But again, yes, I've said let us talk about despite the fact that the health insurance is working, talking about the NHIF, the ICHF together with the private insurers are working hand in hand with the government, but still the government is getting a burden in the areas of there are some people who are not capable, who cannot pay the premiums given under various insurances. So we think the experience of ICHF having a premium which is affordable, as it has been mentioned earlier, it give a room for them to get involved in the fund. Why? The premiums which is still operating today, and we are sure that it is still so low, but experience of CHF which has been involving communities, all various stakeholders, gives a room for us to set a premium which will make sure that everybody who are, especially those who are in the informal sector, can manage to pay it. So with this one, again, I say it is important to involve the ICHF in the coming the UH bill. But again, we think that the ICHF, for example, today we have 26 pools we have got in the various regions. We have made some improvement today. Our plan is to come to be full-flagged CHF fund, insurance fund. So already we have done the following. After opening the accounts at the regional level, where we have two accounts, the collection account and the expenditure account, now we have managed to open an account at the national level at BOT, whereby all the funds which are collected at the regions are taken before they are being used. They go to the BOT. Then from there, the regions can access those funds and make use of the funds for various services, including paying of the claims reimbursement to the health facilities which has given services to CHF members. But again, we have made some improvement in the areas of the ICT system. The IMIS, CHF IMIS, has been integrated with the other ICT systems. You know, I think you remember the guest of honor, Dr. Molel, has commented that various ICT systems in health sector are still not integrated to each other. But for the case of ICHF, we have made a milestone again. We have integrated with the GoTiomis. We have integrated with the MUSE. The GoTiomis is the government health management system for managing the healthy services at primary health care. So we have integrated with this. We have integrated with GPG so that's to manage the ICH fund. That previously we had the money we are collected manually. So with this now we have made a milestone to make sure that members, when they pay their contributions, they pay through they are given a control number and they pay. So this one again we have managed to control wastage of or loss of the contributions of the members. But we have just a minute, yeah, okay. Yes, a lot of. The other thing is the way with the MUSE that the expenses of let the ICH fund be accounted. That it follow the accounting system of the government. And lastly, we have again merged the ICF integrated with the Afya Care, the system or the ICT system which is taking care of health services at the secondary and the tertiary level. So with all this which we have, and plus those which have been mentioned by Dr. Manfred, we think we have a chance to go ahead to work under UHI. Thank you.
Thank you very much, Mr. Maganza. You point out well the advantage and what are the next steps that PURAG is doing also, and you give us update on several areas. And it looks like, yeah, we are in the good track kwa usimamizi wenu PURAG. Based on what Mr. Maganza has mentioned, Mr. Ali Kebi, can you actually Mr. Kebe, with your experience with the HPSS project in reforming the community health fund, and currently we had a lot from Manfred about what HPSS project has done on this area. Do you have any other addition on what Mr. Manfred has mentioned in terms of supporting its implementation at the national level to contribute to the achievement of the government aspiration of universal health insurance.
Thank you very much, Cookie. Basically, Manfred has highlighted some key points that need to be considered. I would like just to amplify what he said, but also reflecting on the government plans and strategies. Looking back 10 years ago, why we have this health insurance, why we have these reforms. The reforms were introduced with the aim that government one day will come with a comprehensive health insurance plan for the population of Tanzania. So according to the policy document, we were aiming at arriving to a point where we would have a single national health insurance. And several interventions were implemented and some analysis were done. And later on, there's been an improvement in that policy goal. Now we are going for the UHI. So what lessons have we learned from the CHF elaboration that could inform the government plan and so to achieve what it has intended? We have learned quite a lot of lessons. As the scheme is progressing, is mutating from a community-based insurance, from a facility-based insurance, to a kind of social health insurance that serves the purpose of different segment of the population. We are looking now, some companies are enrolling their employees into this scheme because they've seen the value, they've seen that it's affordable, but they see that can also provide services that are needed by the population. So are the individuals. So with that flexibility, that individual could join, groups could join, an employer could enroll the workers, it really creates a very good ground for the government while they are working on developing a comprehensive plan for health insurance for all. So they have to see and understand what lesson we have learned throughout the process. How are the poor people have been integrated in this scheme? What have they benefited from? What are the areas that need to be further improved? I will just mention 5 years ago, there was a study we did with one student. She's no longer a student, called from Heidelberg University. She was looking at the inclusion of the poor in the insurance. One of the areas that she came find out was the issue of transport. Yes, the poor people can get insurance card. These were TASAF beneficiaries, around 60 plus years old. But when they get referral, they were unable to travel from their village to the nearby referral points. So you can have an insurance, but if you don't have a transport means, that is also not helping these people in the field. So that also needs to be considered as we are expanding ambulatory services, as we are expanding the M-Mama transport facility. How can insurance introduce these transport packages? Is it possible or not possible? So all this kind of lessons that CHF is bringing on could be taken up and the government could learn so to inform what is currently being developed at a policy level. Thank you very much.
Asante sana Mr. Ali Kebe. Naomba niende direct now kwa hawa implementer ambao wamefanya hizi kazi, na naomba nianze kwenye level ya chini and then tunapanda juu kupata ile experience yako. Dr. Oswald, unaweza ukatuelezea uzoefu wako kwenye CHF iliboreshwa implementation yake yote kutoka kwenye kituo chako, kwa sababu wewe unafanya kazi. Utuelezee kidogo wale beneficiaries wa CHF na jinsi unavyowahudumia pamoja na any success stories ambazo unazo kuhusiana na CHF. Mike.
Asante. Mimi ni moja ya watoa huduma kwa wateja wa CHF na ICHF, na experience ya kutosha ya kuona kwa ngazi ya dispensary. Kwa hiyo sasa tuzungumzie hawa wateja wetu au wanufaika wa CHF kabla haijawa ICHF. Nimekaa hapa kwa sababu kituo changu ninachokiongoza kimewaona wateja wengi sana wa CHF na ICHF. Na kimsingi kama tutakuwa na bima kwa wote, tunatakiwa tuanze kujifunza au kuangalia CHF, ICHF imefanyaje kuweza kuwapata hawa wateja ili tuende na mfumo huo. Wanufaika ni watu wa kawaida kama ilivyosemwa kwamba ni wale wote ambao wanatoka kwenye zile sekta zisizo rasmi, ambao ni watu wa kipato cha chini. Ni kweli sisi tunaowaona wengi wao ni Watanzania ambao wana kipato cha chini, lakini watakuja kwenye kituo chako, watapata huduma kwenye kituo chako kama mambo ya msingi yakifanywa na kituo. Kwanza, good customer care ya wateja hawa. Sisi tulipata wateja wengi kwa sababu toka day one zilipoletwa hizi program tuliwapokea bila kumneglect mtu au kumfanyia tendo lolote ambalo angeona ametengwa kutokana na bima yake. Lakini la pili, mtoa huduma kituoni yupo au wapo? Mteja anachukua muda gani katika eneo lako la kituo cha kutolea huduma? Sisi kituo chetu tumemaintain kwamba watendaji tunakuwepo muda wote, na wateja wetu hawachukui muda mrefu kupata huduma, lakini zikiwa katika standard inayotakiwa. Lakini pia tumemaintain upatikanaji wa dawa muda wote. Kwa hiyo wateja wetu wanaokuja kwenye kituo ambacho nakiongoza mara zote wamepata huduma ya consultation, vipimo vya maabara, lakini pia wamepata dawa na kuondoka nazo.
Asante Dr. Oswald, je, unaweza ukatuelezea yani jinsi gani katika wananchi ambao unahudumia kwenye facility yako, wengi ni wateja wa bima au out of pocket au CHF?
Sawa. Kwa sasa hivi kwa mwaka huu wote kuanzia mwaka 2022 mpaka sasa hivi wateja wanaoongoza kwenye kituo changu ni wa CHF. Wateja wachache sana wa NHIF, wateja wachache sana ambao wanalipia papo kwa papo. Na hii ni kutokana na kituo tulivyojitengeneza. Kila mteja anayekuja kwa kulipa papo kwa papo, tunampa elimu kwamba kuna bima ICHF ina gharama nafuu, lakini pia imeboreshwa. Utapata huduma kwenye ngazi ya dispensary, health center, district mpaka ngazi ya mkoa, ukifuatwa na zile taratibu ambazo zimeainishwa katika miongozo ya ICHF.
Asante sana Mr. Oswald kwa maelezo. Naomba nimuulize tena Dr. Ali kutoka Mbagala. The same experience yako kwenye kuwahudumia wateja wa CHF na kama kuna changamoto zozote na kutupa uzoefu wako kwenye hilo, na what are the challenges ambazo unaziona?
Sawa, asante sana moderator. Wakubwa shikamoni. Yeah, kwa Kiingereza.
Okay, I can do that.
Yeah, I was asked the two questions. One, ICHF elaboration contribution on improving access to health facilities, And the second question was the financial contribution of ICH Ilioboreshwa in our facility. In the number one question, it is true that the ICHF Ilioboreshwa improves the access to health facilities because in reality it is cheaper compared to other health service insurance schemes, and also it is obtained at the level of the community and at the level of the health facilities, meaning starting from the enrollment and getting the services. Nowadays, once the client is registered, straight away he or she gets the service from the facility. Comparing to the previous time when the patient was given the grace period of 2 weeks before getting the service. Now the services, the access is improved so much. Also, the community feels a sense of ownership because they can debate. One, she or he can decide to join the insurance scheme of 40,000 or the insurance schemes for the whole family. That is 150,000 per family. Also, the service is integrated. It is integrated in the health services. They are not separated. That the patients or clients who have ICHF card, they are not getting services from different rooms. The services is integrated with the other insurance schemes, NHIF, and other programs of the user fee. And now the point of discrimination is not there. Also, no additional cost is added to the patient or clients. Only the insurance is used to the insurance is used for the patient to get all the services required at that time. Also, we make sure that all the products are available at the hospital. No missed item is allowed in our facility. All the medicines are there.
Okay.
Also, in the part of the financial contribution of ICHF Ilioboreshwa in our facility, yes, it has great contribution in the part of revenue correction. It was started in the year 2020, where we corrected 0 in that year because it was a starting point where the health workers were trained and the installation of the systems to enroll and to give the services through the IT services. Now, afterward, the revenue was highly increased in the part of CHF. For example, in the year 2021, we planned to correct 2 million shilling from CHF. We corrected 53 million. In the year 21-22, we planned to correct 200 million. We corrected it to 55 million from CHF. Also, the exemptions is tremendously reduced. At the first time, we have been exempted more than 50 million shillings per month, but now we exempt around 20 million because there is a big enrollment of the clients in the ICHF scheme. Also, Also, ICHF helps us to give timely statutory benefits of the health workers. Also, it helps us with the NHIF. We managed to employ 61 contracted workers. Also, we managed to have adequate and in quantity and quality health commodities. Also, we managed to give tea and bread to the staff who are working in the maternity block. That is the advantage of the CHF.
Thank you very much, Doctor, for, the wonderful, and you did mention also you managed to pay now statutory benefit for the staff timely, and you reduce the exemption up to 20 million.
Yeah.
That's good. On that end, Dr. Ibenze, can you also share with us your experience, because we know that CHF was established with the objective of ensuring people contribute to the healthcare service before they fall ill and complete actually treatment. From your experience in managing services at regional referral health, hospital, how is this objective being realized?
Okay, thank you. Thank you to all. Actually, with respect to the improved CHF, with the regional referral hospitals, where we found most of the specialized care now are taking the advanced investigation are being done there. The aim of reaching the region, because at the beginning we know with CHF was aimed to reach only the district, but once it was improved, it was now extended to reach the regional referral hospital. Yes, for example, at our hospital we usually receive 1,200 to 1,500 patients in a day. Among them, which are maybe the 100, which is almost 60 to 80% of the patients who come at our hospital, they usually come with the CHF. The CHF, yes, it is helping a lot to the poor people actually who are fall sick. Once they reach at our hospital, because we don't actually deal with people who are not sick. When they come to the hospital, they are already sick. So most of them, the cost for legislation, for cost for investigation, for those who reach the point of being admitted, they also benefit from the admission fee. And most of the investigation actually they get them through the CHF. However, some of them, for example, the CT scan, sometimes maybe because they are not included in the CHF catalog, sometimes become a problem. However, because the good government of Tanzania has established a system for those who are not to afford such costs, they usually being exempted. So the aim, which actually was aimed by establishing the CHF, in most of the cases now it's reaching the goal. However, some of the costs, yes, sometimes they cannot afford, but through the means, the organization which have been made in the arrangement, most of the people they get treated in the hospital without any difficulty.
Thank you very much, Doctor, for the nice clarification. Now we go to Mr. Kisawike, who is the CHF regional coordinator. We know that the reform on CHF now move the pool to the regional level, and we know the implementation of the CHF now at the regional level, it's a process, and the region currently have the mandate to operationalize it on daily calls with the fund pooling, and with all its administration, including the advocacy and etc. How has it worked? Maybe better at your region, and what do you consider to be a success and also maybe you can highlight one of or two of the challenge. Karibu, Doctor.
Thank you very much, Mr. Moderator. It's so clear that the management of ICHF as a microinsurance scheme needs the availability of resources. Basically, the resource here is human resource. Management of ICHF require reliable structure that compose effective and efficient human resource for coordination of the schemes, technical backstopping, and information flow, and also management of the fund. With this case, the regional structure, it's proven to be best fit of it. So cascading the operationalization of ICHF region, it's proven to be the best because in most cases, most of activities and operations are conducted from the regional levels. For our case in Dar es Salaam, for instance, there are sometimes our correction per annum, it's reached from 2 to 3 billion. And management of this fund require human resource who are effective and efficient. Also paying to capitation to health facilities, we are paying from 200,000 to 250 per month to the health facilities. Also, this require resources. And for the case of Dar es Salaam also, the issue of promotions, sensitizations, and also enrollment require resources. So cascading the ICHF to the region is very important because most of the activities and the natures of the peoples are well known by the region itself. Thank you.
Thank you very much. And I think we have covered. Now I can let anyone who has any contribution on any clarity, please. I will take 3, and then if I see many end, I can add up to 4, and then I'll give the room for the panelists to respond. Anyone to help me with the mic? Yes.
Thank you, moderator and panelists, for such very critical conversation, especially in this time. I have one question to Mr. Maganza, and I think Mr. Kebi will assist if you have any comment. Despite the improvement that we have done and that we really appreciate, but still we miss a good number of Tanzanians on the scheme. And during the presentation, Mr. Man has admitted the lacking part of marketing and branding. So from your experience, do you think what important issues we are still lacking on the part of the marketing and the branding? But also, Mr. Maganza, you will assist me with, from your experience, how do you manage to avoid fraud and any kind of cheating, especially that has been the common challenge in most of health insurance schemes. Thank you.
Thank you very much. Do we have anyone who have any? Yes, Karibu.
Mr. Chairman, I know 2 things. One, you know, any business starts slow and grows. But it grows because you learn experiences. This question of CHF has got its own growth pattern. You don't take into consideration. You see, when we started, just waiting for people to die. Either you pay or you die. Or you are, and therefore, the establishment of CHF enabled dispensaries to have more resources managed by this fund. Secondly, duty of the government to see as the improvement of the aims of the people come up, they will send it up. 30,000 we are saying now is not the end. It's the beginning of a long journey. Just like when we started with NHIF, there was the same. So that's one thing I want we all to follow. Follow up the way in which income of the people goes up. And then ensure that all people join. This is a second very important issue. Expenses. Because not all people get sick. And ICHF should ensure that there is a training that goes on to make people not get sick. These are three things. If you forget, thank you, Mr. Chairman.
Thank you very much, Professor Meshak. Professor Meshak ameongea kwenye experience alionayo ya muda mrefu na ametushauri vizuri. Do we have any comment? Anyone who want to? Kaka, kuna Dr. pale. I think this will be the last, and then we can give. Okay, that one will be the last one, and then we can give the room to the panelists to provide their feedback, not necessarily responding, but to provide your feedback on the comments, contribution. Thank you very much, Doctor. And I think that one is the last one. Over there.
Oh, thank you very much, moderator. And as others have commented, I really appreciate the great and significant contributions of our partners and the government, Swiss government in general, because I've been in all the processes since the pilot of the interventions implemented with the support of Swiss TPH and until its actual implementations. And to be a question, I'm taking it myself as I'm advising myself that this important platform, because Minister of Health officials are here, your officials are here, this could be a very important platform when we are proceeding towards universal health insurance agenda, because I know there will be a series of discussions and improvement to take it. Can we use platform, important platform for inputting what is already there in our bill for universal health insurance? So it depends on the cost, convening all, but I know those who have been implementing and those who have been supervising at all levels, up to the PRAG levels, are very important stakeholders in make sure that when the Universal Health Insurance Act is executed, it has taken all these inputs. But when talking about equity, and this goes to Mr. Maganza, I want to know just your experience. I'm not supposed to ask you, but just your sharing experiences on the equity issues. We have seen panelists commenting on cross-regions benefits that previously before ICHF, on the facility, especially the primary healthcare facilities, we are benefiting. But now a member can go up to the regional hospitals of any of the regions in Tanzania mainland. But there is an issue of tertiary level hospitals, and they have been getting concerns from ICHF members that why can't this card or my membership benefit me if we are talking about equity among different health insurance schemes? Why can't it take me also to the tertiary level? For example, in Dar es Salaam, when I go to Ocean Road, when I go to Muimbiri, when I go to JKCI, the other insurance, like national insurance schemes, members can benefit the same with the ACHF members. That is the concern that we also been receiving from our clients. I want to know your experience on that. But the other issue is PPP arrangement within the ICHF. Because we see in NHIF, a member of NHIF can access services if private for profit, private to non-profit as facilities. So I think that is that area also to look into when you are going to national health insurance, but also because the ICHF will not die within the national health insurance schemes. So I think that is an area also we have to take into consideration. The other area is specialized in super specialized services. That is an area that also has been taken on board. Lastly, what about insuring the poor? Because the aim of CHF and ICHF was to make sure that those who cannot afford to pay an 100% benefit. When you look into the CHF Act, that was the main purpose. But now we can see even within the CHF, there are those who cannot afford to pay, within the NHIF also. That's why we see the government came with a matching fund, complementing what a member is paying. And even in the Universal Insurance Act, I think that is coming on how can the subsidy implemented, how can the government now add up or top up? Now we had the matching fund before, and we're now not hearing again about the matching fund, because I'm sure for example, Dar es Salaam, 40,000 that is paid by a single person, and a costing study, if you do a thorough costing study, cannot suffice all the services from the primary to tertiary level per year. We need a subsidy and topping up like matching fund. So what is your experience? So all my questions go to Maganza, the policy supervisor. Thank you very much.
Thank you very much for the question. We have had a different question, and there are some question which is the policy level question. I think maybe Mr. Maganza, or maybe if you don't have the answer, it's okay in terms of financing the poor. But I think there are some question which we can provide some feedback, and we can all contribute to get some answers of those questions. I'll give you, each one of you, I'll give you 2 minutes to comment. And Mr. Maganza, I know you have a lot of questions, but I would like also when you finalize the session and the question for Mr. Maganza, we have learned a lot from the implementation of the CHF and different reform, and we have seen a lot of the good lessons and some of the challenges that have been highlighted by the actual implementer, the provider at the facility regarding the CHF members. Now, what lesson learned from the implementation of the ICHF, I mean, consideration on informing the policy, as the previous member mentioned, the policy and strategies for the development of UHI, for the realization of the UHC. And also, Mr. Kebi, also you can highlight a little bit on, as the government currently is embarking on development of UHI strategies, what are the most important areas to be considered for the successfulness of UHI and realization of the UHC in general? So I'll start with Dr. Ibiza, and then we'll go to Dr. Oswald, and then Musa, and then we'll go to the Dar es Salaam, Dr. Kasike, and then Mr. Ali Kebe, and then Mr. Maganza. Karibuni.
Okay, thank you. Let's respond on the experience of the health worker over the legislation of CHF. Previously, actually, in the health facility, we experienced a number of patients who came. They are just being treated by exemption. In most cases, when started the community health fund, it lived a lot over the exemption. So if you come to our health facilities, currently you will find we have the centers which actually they deal only with legislation of patients by the who are they just register people for on CHF. So most of the if you come to the hospital, I know we like cash money, but for those who they don't come with money, we encourage them to go then they register for CHF, and it's being done a lot in the health facility. Now currently across all the regional referral hospital, I'm also the chairman of the medical officer in charge in Tanzania. So I usually follow a lot of the issues. One of the issue about the registration of people on CHF. So over the improved CHF, now every regional referral hospital currently they have a registration point at the hospital which they do registration for the patients. So the encouragement is it's high, and it is done well in the facilities. Thank you.
Thank you very much. Dr. Oswald?
Yeah,
Quick.
for me, I can say this ICHF, we can take it as a fundamental method to go to the universal health insurance, because it can occupy even the people who are low income, and to accommodate a lot of people. Secondly, I can say we need to bring the awareness that ICHF is there, it is continuing to proceed, so people can go and enroll to be a member and to benefit with our health services. That is what I can say.
Thank you very much. Dr. Alice, please.
Yes, I have two things. Number one is a request that we are requesting the rectification of the disbursement after treating the patient. It takes too long to get the money from the organs who are responsible to pay us as health providers. Also, the second one also is a request, if at all possible, to make a modification that CHF to be like NHIF. If you treat any member of the CHF, the payments come to you directly. For example, for those patients or clients who are coming from the upcountry, when you treat them, you have to request the payment from the other region. You are not getting the direct payment after providing the service.
Thank you very much. I think Mr. Bagonza has explained a little bit on that. Like now they are looking at pulling at the central level. Please, Mr. Kasi.
Thanks. To me, ICHF paved the way to universal health coverage. As others comment that ICHF leave no one behind. And in order to achieve universal health insurance, there's a lot to learn from ICHF. ICHF, as the days goes on, for the case, for instance, for the case of Dar es Salaam, it sometimes the capitation paid suffice the services due to the pool we have. For instance, there are sometimes our capitation index reached to 117. So 117,000, this may suffice the services from the district level up to regional referral levels. Such kind of index may cover for those who their services exceed more than such amount. So with capitation mode of payment, This is very important lesson to learn when we are approaching universal health coverage.
Thank you, Mr. Ali Kebi, and then Mr. Maganza will wind up.
Thank you very much. Maybe before reacting to your question, I would like also to respond to a question from Anodi, and that's to complement what Maganza perhaps would say. With regard to the issue in relation to branding and marketing, what have we learned? So as we are implementing these reforms, we have a big segment of a population who are still linking the improved CHF to the old CHF, the conventional CHF, which has many challenges. So it took time to educate the people and so to internalize the different changes between the two schemes. So one of the issue that the CHF, ICHF or CHF Europe Boreswa had suffered image-wise was the history of the previous CHF. As we continue, we had many partners who were paying for the poor families and wazee. So other people, they dub it bima ya wazee, bima ya maskini, bima ya watoto yatima, and the other people were refraining from joining that insurance. So we have to work on that line again to make sure that that understanding is well addressed and the misconceptions are cleared. As we continue, we started seeing other organizations are bringing other beneficiaries. Now we are targeting people from the informal, formal sector and the formal sector into CHF. So branding has started targeting different groups so they can look at it and resonate with CHF. So it's not a one-year project that you can do and achieve, because also branding requires a lot of process. You have to do research to identify what are the misconceptions, how are people relate that issue to, and thereafter you come up with a counter mechanism. That process has already been informed by one of our study research. We have come to understand how people perceive CHF, but also the other study have given us a feedback that 60% of the interviewee in the enumeration areas, they've got an understanding of CHF Europe Boreswa, but they are lacking a better understanding of what the benefit packages are. So that's one of the areas that we still have to work on it as in terms of the government going forward. So looking ahead in the UHI, how could it be successfully? What lessons we take again from CHF? I think, as others have said, the UHI must be dynamic, should be able to address the different needs of the populations, not on the ability to pay. Because the ability to pay is another thing and needs are another thing. I might be needing a certain kind of service, but I'm not able to pay for that service. How could that policy be formulated to ensure that everyone will have equitable access to all the services, not confining those with low ability to pay to only a primary service of care, for instance, and they are not able to access the tertiary and secondary level of care. So these are the kind of things to look into and see what CHF have done. Dr. Ibenzi have mentioned here at the referral level what kind of services are they providing. Dr. Mfaume has mentioned, is it possible for CHF members, forget about CHF, for people who are able to pay the current rate of premium, be able to access services at Muhimbili or at whatever super specialized facility in the country? That need to be looked into. What are the real costs? At the moment, do we know the cost for all the procedures that we are offering in the service, in the facilities? I doubt if we know, because if I go to Ibenzi's facility, I need to do a certain kind of procedure. That service will be charged differently. If I go to Morogoro RRH for the similar kind of service, they will be charging different rates. So we need first and foremost to understand the real cost and inform that process of pricing of services, and then determine what rate of premium could be charged in order for all the population to benefit. And of course, there should be cross subsidization and subsidies from the government. Asante sana.
Thank you very much for that clarity. Mr. Maganza, please, if you can quick and then we can.
Okay, thank you. Going straight to the various questions which has been raised, some of them has been responded, so I'll just say add or tackle those ones which were not taken care. The issue of branding, thank you, Mr. Kevi. I think you have done it. About the issue of fraud and cheating and so forth, as we have said, we have migrated from manual works, including the collection of funds, registration process, and the collection of funds. So we went into the digital system using the ICHF, IMIS. So today we can collect funds and spend them using the digital situation. So with that, again, during the process of taking care of the clients, when they go to the health facility, before they get start getting service, when they go to the point of registration, they need to be identified. So there is a verification process whereby we can identify the real customer who has come to get services in our particular facilities. So this, we find it is one of the intervention to control those ones who can come get the services while they are not mandated or they are not required. But again, when you go about we have the issue of processing the claims, we are using again the ICHF, the IMIS system, the IMIS ICT system is the one which is connected to all the facilities, so that the requirements, the claims are fed, what has been taken care by the client is fed to the system. The claims are sent to the regional level. They are sent electronically, but plus those ones which are sent through the manual, the hard copies. So this is a cross, or I can say it's like a checks and balance in that area. But again, in general, we have the internal auditors at all levels, at council level, at regional level, but the internal auditors are auditing the fund, the ICHF fund, together with the other government funds. But again, we have the external auditors for taking care in those areas, but not forgetting the CAG. Whenever the CAG goes there, he's, among other things, takes care of the management of the ICHF fund. And we think we need some more improvement as we are going to UHI as far as this area is concerned. Thank you, Professor Meshach, for your comments. Lil, the CHF pattern need to be understood, and its growth pattern has something to do. But again, it was about the attitude of the health workers. I think Sakebi has said as far as CHF is concerned. But we think, for example, we have made some various preparations to go to take care even those ones who are ready from you know, if we can talk about the informal sector. We know the informal itself has got the informal per se and the informal formal. There are those who can, the informal per se are those ones who can pay maybe the premium, say, once, or through paying little. We are thinking of, we have to develop a mechanism whereby a member can pay slowly, little, until he completes their own premium. But again, for those informal form, who can pay through their little salaries they are getting, again, we have developed a solution whereby can help to make sure that those ones who can pay what they have from their little salaries they have, to make sure that they access the fund. So these are the areas. So with this, you find even those employees under formal sector, they are even planning, they had been requesting to come and get the services which are provided by the ICHF. About the issue of subsidy, yeah, of course, the CHF by itself, it needs to have a matching fund. But having a challenge in the areas of matching fund, our task, we think that if CHF becomes to be mandatory, you know, as per today, the ICHF or CHF is just a voluntary fund. Is where we are moving. We hope that now it will be mandatory. And if we can consider the target population of it, which is in the informal sector. So we hope that if it becomes mandatory, as it has been said previous, that a lot, majority of them will join the fund. So even the issue of cross-subsidization together with the risk pooling, we hope that will be overseen in it. Yeah, the issue of reimbursement issues, which has been raised, we, you know, since we started the ICHF in July 2018 with the IMC system, we had been making some improvement in the ICT system infrastructure. So currently we have resolved the problem by purchasing some more 2 ICT servers, so as to increase the capacity of the ICT system, so that it will be to take care timely reimbursement of the health facilities. But again, with the improvement which we have made, coming with the MUSE solution, now through MUSE, health facilities who has given services to our customers will be paid promptly, because now there will be any further delay. So these are the much which has been done to let the fund to be able to solve all the challenges which has been existing on the field and to be ready to go for the coming UHI. Yeah, as far as what we have learned, I think, thank you, Mr. Kebi, you have said it should be dynamics and all whatever you have said. So, our task, the CHF in the coming UHI, we think that we are thinking ourselves, as basing from our experience, we think that to have a premium, to have types of benefit packages, or more than 2 benefit packages, a benefit package which should be a minimum benefit package, which can cover those ones whom cannot manage to pay the higher levels of premiums. So this one, not only will it end to the region as we are today, to the regional referral hospitals, this one will go as far as to the national level and cross-cut even to the private service providers. I think Dr. Mfaume has said this, that, okay, what are the future plans of the ICHF as far as the PPPP? You know, today we are paying through capitation, but Dr. Manfred has said that IMIS system has an option of the ICHF fund to develop various products to make sure that, or various solutions to make sure that all stakeholders who are involved in CHF can access or are happy or remains comfortable in that fund. So all these solutions allows us to shift. For example, now we are paying by capitation, which discourages most of the some of the private sectors. But if you go to Dar es Salaam, for example, Dar es Salaam and Dodoma, private sectors are seeking to go and are requesting, including the Muimbili. I think Dr. Mfaume himself, together with Yasin, can explain this. We have the Aga Khan, what was that? It is Dr. Kairuk Hospital has came to request that he needed to provide the service for CHF members. So, as I'm saying, today we have the capitation, but we are ready, even ourselves, to go to pay cost for even each services which a client has got. But the issue is, as I've said, as Mr. Kebi has said, the issue is what we have to have a standardized costs for the public services and for those ones who are working, providers who are working under profit. So these, we think, are the issues which we think we need to address as we go ahead for the coming universal health insurance. Thank you.
Thank you very much, Maganza. Thank you very much, all the panelists. We have heard from the central level in terms of PRH, what are the
current future direction and on improved CHF and what are their plan and what they have done so far in terms of improving the system. We have heard from some senior here that the pattern, actually the process, has to be well understood, and also its growth. Where are we coming from with the CHF up to now? A lot have been done, and that have been also mentioned by different health provider that we have at different facility level. We have pure public facility, and we have those parastatal facilities that are operated with different government institution, and they have mentioned a little bit of good testimony of what actually CHF has done and has changed in terms of accessibility. Now they see more patient CHF clients at their facility, and also it's improved their finances at the facilities, and now they are able to do. So I think all of these reforms take stepwise approach. You cannot have the complete set of everything. So as part of the expertise, I think we need actually to think more and keep on brainstorming of on all of these different. And also we had the issue of altitude from the Manyara dispensary that they are treating well. That's why a lot of patients of CHF are coming there at facility. So we have a lot of success, but we have also some challenges which we as experts, we need to keep on dialoguing them and coming up with a good. With that few remarks, I would like to thank you all, and please let's claps makofi mengi kwa ndugu zetu, and asanteni sana. Jamani, asanteni.
Thank you very much. Thank you. Manfred banks harder than anybody. All right. Who is using a wristwatch like me these days? What is the time now? Yeah. So you'll agree with me that time was really elapsed. This panel discussion has been granted almost an hour for each. We started at around 2, but because it was the first experience, we have spent more time than we planned. We did not want to cut it short, because actually these kind of discussions are what brought us here. We needed to critically reflect on these issues. We are closing the project, but we are not closing the business. The business has to continue. So we uptake the best practices, but we need to identify some gaps that the government will start working on when the project is closing down. So it was very important to spend the time the way we've spent. That being the case, I'm not going to be participatory now. I decide on your behalf that we shall not take the second panel discussion today because people are tired. This is the first time I've seen a dictatorship is being applauded. So we shall close the day today here. But I have an announcement. Everybody who fortunately was one of the people who were awarded today, please see Madam Fiona when we stand up and move out of this room. We recommend that they take a joint photo as a group, everybody who has received the award, including those who were representative, even if dada Rehema ukupata zawadi yako nadhani. Kwa hiyo, but you go because you received something on behalf of somebody. Please attend that session. Otherwise, I thank everybody who was here today for your contribution. Some of us, our contribution has been in listening to what has been going on and try to ponder. I know we still have time tomorrow where we can use the knowledge, experience, and whatever that we learned today to contribute to the successive session tomorrow. But otherwise, everybody's presence had made the day. So we thank you very much for that. And remember, we have our lunch. Our postponed lunch is waiting for us. So let's do saving today. No boat dinners. We eat our late lunch and then we go to sleep. And the savings can be used for buying some gift and present when you go home after the workshop. Thank you very much for the organizers and every supporting staff who has made this day a reality. Otherwise, let's keep time tomorrow. You all have the program. We start very early. We would really wish to make sure that we close at the planned time as scheduled. Muende na baraka za Mwenyezi Mungu.